colleagues and friends. Welcome to this very interesting webinars about a very interesting topics. And we are having an eminent speakers. I'm proud to have today with me Dr. Carlos Matthew and Dr. Brian Kim, Dr. Aspen Agarel, and we are having also my dear friend Dr. Safwan Al-Bayati. And we are going to talk today about all different types of secondary IOL implantation, how to do this, how to perform the procedure step by step, what is the advantage and disadvantage, and anyone of you can raise his hand and ask the question anytime so we can have an interactive sessions. I would like to thank also Donatus for sponsoring this meeting, and thanks for Marvision for as a management event for these webinars. I will start now with Dr. Carlos Matthew to give his talk. Then we can have the question and interactive sessions. Dr. Carlos, please.
Thank you, Mohammed. First of all, I want to thank you for your kind invitation to be here. Let me share the screen. Okay, you can see the presentation now?
Yes.
Okay, as a vitreoretinal surgeon, my topic will be a little bit different. I'm going to discuss to be or not to be, to rescue or to exchange in patients that have luxated IOLs. You know that the reported incidence of luxated IOLs varies from 0.05% to 3%, and there are contradictory reports about if the rates are increasing or not. You know that risk factors for dislocated IOLs are cell-dose foliation. Perhaps it's much more common that whenever you see this material in the lens, previous vitreoretinal surgery, myopia, secondary implantation, glaucoma, sonora dehiscence during cataract procedure, and trauma. This location is not related to any particular IOL, and it has been reported in rigid foldable acrylic silicone, one piece, three pieces, and different IOL designs. When you face a patient with a dislocated IOL, you have two main ways to deal with. One is to rescue the same lens the patient have, or to exchange. My colleagues, they are experts and they are going to speak about exchange. And there are so many possibilities. You have a third chamber, IOLs, iris fixation with sutures, without sutures, a scleral fixation with sutures, sutureless, with special lenses, Carle-Valley lens, etc. But I'm going to speak about to rescue lenses. I'm going to speak about three techniques I use when I have to deal with patients that have dislocated IOLs. Why I prefer to rescue these lenses in patients with dislocated IOLs, for me, first is because you have a faster recovery time. It's a cost-effective procedure. The eye remains closed, during the entire procedure, and you don't need to reopen the corneal wound, no iris prolapse, less postoperative astigmatism, and less endothelial cells loss. You will have better stability during the procedure with less risk of hemorrhagic events. Evidently, not all lenses are nice for recovery. These silicone lenses, for example, are not good for recovery, and you have to remove them. My preferred technique at this moment, I have two or three techniques, but one of the most used technique is the iris suture. There are some surgeons, they prefer not to remove all of this, but I remove everything. I remove the cortical material, I remove the capsules, I remove the ring, this kind of rings. I use two forceps trying to avoid to hit the retina, and then I'm going to clean the lens. I'm going to put the lens just in front of the iris surface, the optical part down, and then with a mechanical suture, I'm going to suture this lens to the iris. This is a simple procedure. This is not that difficult to perform. Different lenses require different techniques, but at the end it's the same. You can use sips or not also, and don't forget always to perform a peripheral iridotomy. You know, this is another kind of lenses that was used in Spain a lot of many years ago in high myop patients. These lenses, instead of 2 passes, you need 3 passes, but you know, at the end, the centration is pretty good. But you know, almost every lens you can suture to the iris. It has, if you have optics, you know, you can suture all of these lenses to the posterior surface of the iris. Even if you have a multifocal IOL, you know, 1 week ago I was discussing this topic with anterior segment surgeons. They were very familiar with multifocal IOLs. And even these lenses, you may suture, you can suture these lenses to the very bad support, capsular support that was out. And I decided to, you know, to suture this lens to the posterior surface of the iris using 2 sutures. The centration is very good. It's very important for these patients with multifocal IOLs. And you know, this patient at the end went to 20/20 vision in 1 week, but you have to consider that at the end, the effective position of the lens changes. You know, it's 1 diopter of myopia because the lens is a little bit anterior than the position it was before. This is the aspect of the OCT. But you know, of course, iris suture technique has some problems. That perhaps the worst problem for me is the pupil ovalization or distortion, the cat pupil, the typical cat pupil. Remember that not all parts of the iris move equally when contracting. The pupillary zone and colliarette move more, peripheral iris move less, and then you have to put the suture as peripheral as possible using a small iris bite. But there are other you know, complications has been described, chronic iritis, cystoid macular edema, but this is pretty similar to other techniques, uveitis, glaucoma ephema syndrome, glaucoma because of the pigment dispersion. Let me tell you one thing, perhaps the data of pigmentary dispersion comes from all series when you had a problem and then you leave these lenses, actually soft lenses, in the sulcus, moving free, and then they may induce chafing effect of the posterior iris pigment and promote iris dispersion and glaucoma. But I think that when you suture these lenses to the iris, then the iris move less, of course, and then the chafing effect is less than expected. We don't find patients with, you know, pigmentary glaucoma and that. But you know, as a vitreoretinal surgeon, you have to be aware of this because, you know, imagine this patient has a high myopia and suddenly she developed a macro hole with decreased vision in her only eye. And then I started my vitrectomy, as you can see here, only peripheral vitrectomy. And then I went down, I stand and knock, knock, the lens fall down. Then you have to be used to manage this. And you know, this is the aspect of the patient after doing this. And in other patients, perhaps you have this aspect, and in this aspect, perhaps you have a PVR. And then you have to improve your visualization because for vitreoretinal surgery, visualization is so important. Then in these cases, the thing I do is to remove the lens, not to clean the lens, to remove the capsules, to keep the lens in the eye, and then I suture the lens to the posterior surface of the iris, as you will see now. And then when I have a good visualization, as you can see here, then I proceed with my vitrectomy, peeling membranes, and everything. This is impossible to do if you have a very bad visualization with this, you know, pacification in the capsular bag. But you know, not all lenses you can do the same, and some lenses, and these lenses have been used in US for exchange, the aqueous lens, but in some patients they have the aqueous lens inside. And then I prefer not to remove the lens. I use the Goretex technique for these kind of lenses, for these aqueous lenses. And then I do the same. I do my vitrectomy, complete vitrectomy. I remove all of this, you know, cortical material, the capsules. I clean the lens, and then I use 2 entries. The important point here is you have to up and down, and then down and up to avoid tilting at the end. and then you remove the suture from the other sclerotomy, and you do the same in the other side. As you will see now, using handshake technique, you go up and down, and then down and up, and then the trick part of this technique is the knot. Is at the end to leave the traction to have the lens centered. This is very important. It's critical to have a good good vision for the patient. And it's a tricky point to put the knot in. Advantage of using Goretex is a very resilient suture compared to Proline, more rigid and breakable. It has a high tensile strength, high visibility, is white in color, minimal inflammatory response. To my knowledge, there are no reports of Goretex degradation in ophthalmic or non-ophthalmic literature. Disadvantage is that is off-label suture for the eye, its thickness, as I told you before, it may be difficult to be buried, and the pigmentary reaction has been described in one patient. And then we arrive to the three-pieces lenses. When you have the three-piece lens inside the eye, Gabor Shariat, we mentioned before, in 2007, he described the technique. Then the Auerbach group, they rediscovered the technique using glue optics, and I think Auerbach is going to show the technique. After this, total in Canada, we're using 27 cannulas, and at the end, the technique of shamanic. I use for these three pieces lenses, I recover the lens, I try not to exchange the lens, I clean everything again, and then I use the Yamane technique with, in the beginning, I was using a normal syringes, 30 gauge syringe. I don't use the technique of pulling out the two ends at the same time. I think it's not needed. I pull first one and then I pull the other one. And what's an important thing is this. When you do Yamane technique for exchange, or you have an aphakic patient, you use the first optic, to be inserted in the needle before. This is the technique, the same technique for this case. As you can see, we are cleaning all the capsules and everything. And then we are going to grab the lens, intraocular lens from the bottom using only aspiration. And then we use this, the inferior, I call this the inferior optic first. I think it's the worst way of doing. As you can see here, we put the optic here, but then the second optic is much more difficult. For rescue, I strongly recommend to do just the contrary. You use first, the second optic is much more difficult to be inserted in the needle. This is the Aspen. For me, the best technique now is this one. I grab the lens, as you can see here. I do my vitrectomy, I grab the lens, and then I grab the superior optic, and this is the superior optic that I'm going to put first into the needle, as you can see here. And then we remove the optic out, do the flange, put the optic down to the vitreous cavity, the flange remains out, and then the inferior optic. And this for me is much more easier. This is the contrary when you exchange the lens. But for me, there is one problem with the Yamane technique. This is not here at the slide, but for me, there is one problem with the Yamane technique is the tilting effect. The tilted. Look at this in this patient. This is a patient I did the same, and at the end, perhaps technical issues, but the lens was not so well in position, and at the end the patient showed the capture of the lens in the superior part of the iris. And for me, the tilting is sometimes difficult to manage in the Yamane technique. And you have to remember, not all lenses are the same for Yamane technique. There is one lens that is perfect. I don't have any, proprietary interest, any commercial interest, but Lucia from size, I think, is the best lens to do that. The MA50 that was reported in the Yamane publication, for me, has a problem that this union between the optics and the optical part, sometimes breaks. Then I had one patient, operated 2 weeks ago, and yesterday, 2 weeks later, the lens was perfect. Patient was with very good vision, but at the end broke this union between the optic and the optical part. Then this is for me a problem. You have to choose the right lens at the end. Then in summary, as a vitreoretinal surgeon, I'm not an expert in anterior segment surgery. For me, rescued lenses have some advantages compared to lens replacement in patients that have IOL dislocation. Iris suture lenses are a good option. It's simple and fast surgical technique with similar ratio of complications to other techniques, and other techniques may be useful depending on the IOL type. With the retinal surgeons, we have to master, different techniques to manage dislocated IOLs to improve visualization, minimizing surgical trauma. And that's all I wanted to show you in my presentation. I repeat, I'm a vitreoretinal surgeon. I'm not an anterior segment surgeon, and then I prefer this management of the luxated IOLs. Thank you.
Thank you very much, Dr. Carlos. Can you hear us?
Yeah, absolutely.
It was a very interesting presentation. Excellent. You already moved to all different type of secondary IOL, but from a point of view of posterior segment. But if there is any question from dear here panels to Dr. Carlos, Dr.
I
Safwan.
have one comment to Dr.
Yes.
Carlos. For rescue of hydrophobic, especially one-piece lens without eyelids and doing a scleral iris suturing, I think that slipping of these acrylic material can lead to slip of the lens. Because you didn't mention the polyproline. You are using polyproline when you are suturing to the iris. So slippage was the issues that, apart from the pigment dispersion syndrome that you mentioned, and you mentioned that the lens is fixed. That's why the rate of the pigment dispersion is less, but still we have it, and still the slippage is one of the issues that's why they will recommend a 3-piece for this the iris suturing. Apart from that, you did a best, and you are doing the best.
Let me tell you one thing, Safwan.
Yeah.
I have 3 cases. I did a lot of cases of iris suture, and I suture acrylic lenses with these square borders, and I use only 1-piece lenses. I suture to the iris, no problem, and also the 3 pieces. The 3 lenses that fell down after iris suture. All of them were 3-piece lenses, because I think I don't understand it. And months later, not the day after, months later. I don't know if they rotate with the movements of the eye. But,
the iris dynamics.
The perhaps it's this.
The iris makes those lenses affecting by the movement of the iris. And usually those patients, we need them to dilate. So we try to dilate, and that also affecting. And atrophic part of the iris on the site of the suture.
Yeah, but let me tell you, the 3 of them, only 1 suture failed.
Yeah,
only one. The lens, only 1.
Yeah.
Then you say rotation. It's difficult to say. Oh, rotation. Why only 1? Why not both of them? Both of them. It's different. The mono. The 1-piece lenses. They don't move. Believe me on that. They don't move, because the material is not that hard. It's not that tough. You imbrincate a little bit the suture in the material. Then in the other ones, it's so tough. It's so round, so sleepy. The slippery can happen.
I have on both. I have slippage for the acrylic and for the 3-piece. Anyway, it was a very nice presentation. Dr. Mohammed, for you.
Dr. Brian, you have any comment, or Dr. Aspen, about Dr. Carlos?
I don't have a comment. I just have another way of actually explanting those dropped IOLs. And I published this in 2014 in a British Journal of Ophthalmology also. It's called the Extrusion Cannula Assisted Levitation. So basically, would retinal detachment surgeons use that for RD surgeries to draw out subretinal fluid?
Yes.
And the same device, I kind of removed the silicone sleeve that
Mm.
goes internally inside the tube, inside that metal, this thing. And once you remove it, it becomes like a spear and a fish. So you basically just have to go on top of the optic of the IOL. And it's just an idea for all the other attendees as well who are watching this.
Yes.
And I'll show this in one of my videos. But basically, what I'm doing is the optic of the lens on the retina. I'm just adhering to it, pressing the foot pedal at even at a 400 vacuum. It sucks it like a vacuum cleaner on a plate, and you can just bring it all the way up. You don't really have to go with forceps, because I find the forceps pinching mechanism is more backwards, and that kind of has problems with plate haptic lenses or lenses which you don't have that grab. And
The
you
problem,
probably know.
as you mentioned, and the problem is that when you grab the
Perpendicular.
optics, the point of the forceps can touch the retina,
Correct.
and
That's
even you can force down and you can touch the retina. Then it's
Yes.
perfect to aspirate the lens with the sub
That's right.
tip or whatever technique. Some people do it with the Visualisation tip or whatever, but with the sub tip is perfect
Yeah.
to do it,
Yes.
and it's great.
Excellent. Do we have any questions? We have, I think,
There's one
Dr.
question in the Q&A.
Sorry. Yeah, I
One,
have Dr. Yeah, Dr. Salim. Yeah, sorry.
no, there's one question in the Q&A.
Yeah, there is no, I need, there is a live one. Dr. Salim Muhammad. If
Okay.
if you want to participate with us, can you open the mic for him, Mr. John?
Yes, I'm opening and waiting for response.
Okay, if not, then you can check also Dr. Amr Al Khatib. Hello. Anyone open?
No one, but still waiting
Okay.
for them.
Dr. Muhammad, let
If
us
not,
proceed, and then
yeah,
we'll
there
see,
is.
because we have a lot of things to discuss.
Okay, so let's go now with the. Can we have now Dr.
Ashwin.
Ashpen? He will
Yes.
start to give his talk. Dr.
Okay.
Ashpen Agarel, thank you for being with us and accepting our invitation. We are proud to have you with us. Go
Okay.
ahead.
Thank you, Amri, for having me. Thank you, Dr. Mohammed, and thank you all panelists for being here. Attendees, if you have any questions, please put it in the Q&A, and I will be happy to answer it after my talk. I'm going to show you. I'm going to share my screen now. If you guys can see it, everything is clear.
Yes, go on.
Okay. So I'm going to take you through a workshop for glued IOL. Glued intraocular lens is basically a procedure where we are doing a secondary implantation for an IOL using a three-piece lens. We all know the indications where we will need to use them. Basically, wherever you have an unstable bag or the integrity of the bag complex is lost. Surgical procedure, let's dig straight into it. First up, we really need to make a conjunctival peritomy and cautery at 3 and 9 o'clock position. This depends basically on one major fact is the horizontal white to white. If the horizontal white to white is anywhere below 12, I will make it at 12 millimeters. I will make it at 3 and 9 o'clock. If it's above 12 millimeters, I will go vertical, because the vertical white to white is always going to be a little smaller than or shorter than the horizontal. Here we go. The next up, I'm going to use my scleral flap marker. This is by
Dr. Ashpen, this IOL inside the eye still, right?
no, there's no IOL inside, right? This is just aphakic patient. I'm showing how to
Okay.
do the procedure step by step of glued
Okay.
intraocular lens. After this, I'll show you the procedure where I'm lifting the IOL from inside the eye itself.
Okay.
So I'm using this scleral flat marker. This is basically made by a company called Epsilon. I have no financial interest, but they make this, and this is what the product basically does. It marks out the flaps which I really want to make. And how do I make the flaps? About 2.5 by 2.5 millimeters. Right now, if you ask me, I would go even 2 by 2 millimeters, because the size of my sclerotomies have changed, and I'll tell that very soon. So how do I make these flaps is exactly what I do for my trabeculectomies, just a little smaller, of course, but basically I'm making 3 partial thickness grooves, and then go under the groove and just come out. And that's basically how I make my flaps on both the sides, 3 and 9 o'clock in position. Once I'm done with that, I need to have infusion all the time inside. I do not play with viscoelastic at all. Here I'm putting a trocar AC maintainer. This is a trocar, again, I'm repeating, AC, anterior chamber maintainer. This is not going into the PC. So for anterior segment surgeons, this is ideal, and it really helps them because you don't have to actually wait and view the trocar from behind. Only reasons I probably go posterior nowadays is if there is any cortical or nuclear matter behind, or if the cornea is very hazy or clouded, or if there is a shallow chamber. In those cases, I would go posterior. Okay. The sclerotomy is the next step. The sclerotomy is made with a 23 nowadays, 23 gauge needle, 0.75 millimeters behind the limbus, under the flap. Again, under the flap, watch this, under the flap, 0.75 millimeters behind. Direction of the needle is very important. It has to go directly to the center of the globe, not at the center of the pupil. So if you're going to the center of the pupil, you're going to drag iris root and tissue with you. So that's something you don't want. I next make my corneal incisions. One is a side port entry on my left because I'm a right-hander. And on the right side, I make my main port incision where my intraocular lens will be inserted. Next is my load. Sorry.
Can
Yes.
I have a question, Dr.
Yes.
Aspen? Yeah. The one you are doing that in the under the flap, how far from the limbal area or in the center of the flap, or where you will go?
Okay, so
When you
here we
do
go
the,
again. Just see it again.
if you do
0.75
the penetration going to the back of the, or toward the center
back of the eye.
of the globe.
Yes. Back of the eye says back. You
This,
can even aim at the
okay,
macula.
you are with me?
Are you hearing me? Are you able to hear me?
Muhammad, you are out.
Yeah.
Ashwin, I just need to continue because Muhammad, I think that he lost
Sure,
the
sure,
connection.
sure. I will continue. I'll continue.
No, just wait, because what he meant is that now Muhammad returned back. So
Yeah, you
what he
can
meant,
hear me, Dr. Ashwin, now?
Yes, yes.
Yeah, just we want to know what is the exact point that you are going to do the perforation toward behind the iris.
What point? I'm sorry, I didn't get your question.
If you are going to, this the step that you have done now before going to, inside the eye, you make the flap, this one, the iris, sclerotomy. You are going behind the iris, right?
Yes, it's going behind the iris.
Where is the location that you are going to stop? In the center or in the 2 millimeter? How far from the limbal?
Good. So I lift the flap up and I go 0.75 millimeters or 1 millimeter behind the limbus.
Okay, that's the point. That's
blue limbus. You see the blue limbus?
Here we need, Ashwin, just 1 minute, because this step is very important. We need to explain for the audience why 0.75, because this is different than what we are doing. 0.75, there's a reason, and I need you to say it, because you are more expert than us in that. So please tell us, why 0.75?
0.75 to a millimeter. The reason I go in between this range is because when I externalize the IOL haptics, when they are externalized, I will get a good length. I'm just going to unshare my screen because I think it's important I show you. If I externalize both my haptics, if I have a longer distance from the limbus, I will have very short haptics to tuck in the scleral tunnel. If I have my haptics coming out of sclerotomy, even a 0.25 will make a huge difference to the externalized haptic. I hope I'm getting this through.
Yes,
and please,
it is exactly like that. And this is one of the key of success for this surgery. Because if anyone go beyond 0.75, means that if extend the length of it to, for example, 1 millimeter or 1.5 millimeter, then he will have shortening of the length of the haptics to go in the tunnel. And that's one of the keys. So as far as that I was doing the glute. I know that this is the key. That's why I asked you, why 0.75? Yes, please.
I'm glad you asked. I'm glad you asked.
Thank you very much for you.
Okay, thank you.
Okay.
Thank you, Safwan, to complete when I lost my connection.
Yeah, it's okay.
So after I make my incisions, I'm going to continue after incisions. I'm showing you the loading of the intraocular lens, a 3-piece lens. Usually if you load it, it could load in this fashion. And this is something you do not want in a glued intraocular lens, because what you want to do is basically bring it or externalize a little bit of it and keep it open. The reason I do this is you want this lucky 7 sign. The reason I want a lucky 7 sign is I don't want a springing action of the intraocular lens springing into the eye, because I don't have a bag here. So now what I'm going to do is, once I have inserted the injector in, I have my glued intraocular lens forceps. Now all I need to do is just eject a little bit of that intraocular lens and I can grab it. Now I'm safe. Once I'm safe, I can now inject the whole optic. And while I'm injecting the optic, or even if not, I can externalize one haptic. This is first haptic out. The second haptic is now lying outside the eye through the main incision, if you see here very clearly. What do I do next is my handshake technique. So I first straighten this out. Once I've straightened it out, I insert this into the eye, handshake to my left hand, then through my right hand, go back through the sclerotomy on the right side, grab the tip of the haptic. Very important. If you grab anywhere in the middle of the flange, it will break. Now, this is a point very important for everybody to see. See the amount of haptic I have externalized because I went 0.75. What Dr. Safwan and Dr. Mohammed was saying earlier is the point here. If I went 1 millimeter, 1.5, 2 millimeters behind, my haptic would be probably only maybe even less than half of what is externalized right now. And that is what leads to dislocation. And I'll show you one of those complications as well in one of my cases. Actually, just one case I'll show you after this. Next up, once I have these haptics externalized, I make my Gebauer-Chariot's tunnel, which is an intrascleral groove or a tunnel made at the base of the flap, parallel to the haptic. So as parallel as you can go to the haptic, you just have to take that and tuck it in. The next step, watch this. I make my groove on the left side, and this is probably tougher. If you hold parallel and pull back, it will start going upwards. Here I hold in a sideward fashion and push it in. This is a very small trick, but it's such an important trick. And I would love for you guys to actually respond to me on my social media handle. It's easier to actually explain with smaller videos on that. Coming to the last step probably is gluing. After removing the sclerotomy of, the trocars, of course, is gluing the flap and the conjunctiva. This is pretty much the end of the case and some of the advantages of this procedure. And I'm going to stop the share because I want to show you guys one last video. If I have time, Dr. Mohammed, up to you.
Muhammad, we are not hearing you, Muhammad.
Okay.
No. Yeah.
You can hear me now?
Yeah, I can hear you. I think that Dr. Ashvin, he can continue.
Yeah, please. Yes, go ahead, please. Go ahead, please.
I'm just going to show one more case, which is and then I'll take all the questions in one shot. So this basically was a glued IOL done earlier, and it did have a complication, and I will show you the lens had dislocated. It was a long back done, one of my first few cases where I did not understand the importance of the white to white. The white to white was larger. So that's why in this case, if you look, I knew the flaps, this was a 13 millimeter eye. So in a 13 millimeter eye, the amount of haptic that was externalized, I'll pause this because the amount of haptic that was externalized was less. Okay, so amount of haptic that was externalized was less, and that's why the IOL dropped back. So what do I do in this case? I go oblique. I could have gone even vertical, but this person had a large nose bridge, and I think oblique was way better in this procedure. So you can go oblique as well, and because it's a posterior segment, I'm going posteriorly for a trocar. Now I've made my sclerotomies 0.75 millimeters behind the iris. Again, watch, it's coming behind the iris. I little bit try to extend that wound a little bit. I'm making my side port entry. My main incision is ready. Now, if you see here very clearly, I've probably done an pupilloplasty as well at the end, at that point, and which is very well holding even till now. So I'm really not going to, I'm not really interested in opening up that pupilloplasty or anything. I'm just doing a vitrectomy. I tend to do a normal, I'm going to go a little fast in this. I'm going to make my 3-port. Just in interest of time, I'm going to show only the IOL lifting procedure which I was talking about. Once I'm done with my vitrectomy, so here we have, this is the extrusion cannula. I just go adhere on top of the optic, and that's it. And that's pretty much what I'm doing. I'm not even going close to the retina or anything. Once I have that haptic in my pupillary zone, I'm not even going to extend or remove this IOL, because it's looking like a great IOL. The intraocular lens looks good. It's just that it has gone back. So what I'm doing is externalizing that haptic one. Once I'm done with that, I can actually go back through the sclerotomy on the other side, handshake my way to find the tip of that haptic on the other side. Once I found that haptic tip, and I can just bring it out. So basically I'm re-externalizing the same IOL, but now see the amount of haptic I get to tuck. Once I'm done with that, ensure that I'm ensuring that the intraocular lens is not damaged in any way, checking if the posterior segment is perfectly fine. Other than already damaged retina, there's nothing more for me to do over there. Now I'm tucking my haptics inside in place. And once these are two tucked into place, both my haptics are now into my Gabor Chariot's tunnel. See, again, I'm going in the horizontal fashion to actually tuck this in place. And I always like to suture in case I find that there is going to be a risk. So I already know that one side has dislocated. I always try to suture that sclerotomy just in case to ensure stability of the intraocular lens. I also use the suturing technique in pediatric cases, just for others' knowledge. Now next is just glue. After removing the trocars, I glue the case up. Flaps and conjunctiva are closed, and that's pretty much the end of the case in this one. Thank you.
Thank you, Ashwin, for this nice presentation. It's an excellent. If there is any comment or question to Ashwin from the panelists here, Dr. Brian Kim, I think he is willing to ask. Yes, go ahead, please, Dr. Brian.
So to go back, I think Dr. Carlos had a magnificent techniques and being able to do that as a vitreoretinal surgeon. If the vitreoretinal surgeons in the U.S. knew how to do all that, I wouldn't have to do these secondary IOLs. So, but Ashvin, brilliant as usual. I love the fact that you explained how far away you get from the limbus, the fact that you adjusted, went obliquely, and the fact that you did that lens that was in the posterior segment. And I love the technique where you took the forceps and found the tip through that small pupil. I think that's a great pearl, is that you can inch your way with the forceps towards the tip of the haptic, and then he was able to externalize it. So as usual, well done, Ashwin.
Thank you, Brian.
Dr. Safwan, you have any question to Dr. Ashwin, please?
I think the audience are having a question, which is a pretty...
Yeah, I will take the care about this one, Dr. Ashwin, later on.
Okay.
Yes.
Mike.
Oh,
Mike.
You're muted, Dr. Safwan, you're muted.
Mike.
I'm muted. Sorry.
Now you're...
Yeah, you can go ahead now, Safwan.
No, you're muted again.
Oh.
No, I start now. Now I'm here. Okay. So Dr. Ashwin, the issues is that when we are externalizing the haptics through 0.75, we need to take care about the calculation. From anterior segment point of view, here we are not talking about the outcome, visual outcome related to the refractive error outcome as a residual. So when we are externalizing the haptics through 0.75, we need to consider that the myopic shift, it will be high in those patients, because we are coming up, as Dr. Carlos said, that when we are coming up, the power should be. So we need to consider these things when we are calculating, especially when we have the ability to implant a lens externally, not internally, or rescue the internal lens. Anyway, it was a great technique, and till now we are using it. But with the new technique that we will hear from Brian Kim, I think that we need to take care about those issues. So Brian, come with all with you.
Let's keep I mean the decision for our attendees.
Yes.
Then our discussions. There is one question for Dr. Aspen. They are saying, is it superior to the artisan?
Or the glutathione?
Yeah.
Yeah, I find it any day superior to the artisan. Any day.
What is the drawback you think, or there is something that you are thinking about it from the glue? What is make different? Only you are using glue just to fix, but the
glue,
procedure.
okay. So
Yeah.
glued IOL, actually the terminology is a misnomer. You don't really need the glue. You can suture the flaps down. It's just a catchy name. It rings a bell in everybody's ear, and people want to hear about it. It started off in the OR with Dad and me just talking about it, but then it became a household name after that. But yeah, you can suture the glue. People have asked me because you can do only one case in a time, and you actually if you actually use the glue, you really need to use it for 5 or 6 cases, which you can't do in every OR. So if you want to use it for one case, please don't go ahead and buy a glue. Please just suture the flaps and you're perfectly fine to go. You don't
So we
have
can have another name for that because it's completely different. I mean, it's not only a glue. If you can
so that's
switch.
why the intrascleral haptic fixation came about, and that's what
Aspen,
using the
Aspen,
glue.
I have 3 questions. First, do you use retrovalvular anesthesia? You use topical because you are used to use topical for everything. Then
We use peribulbar in this.
You use perivalvular for to the.
Peribulbar.
Second question is why you don't prefer to use always pars plana, entry instead of putting an anterior chamber cannula. Why you prefer this?
So it depends on the case. As I said before, if the case is more of an anterior segment case, I would do, and if it's a pure aphakia for anterior segment surgeons to learn as well, they are not very comfortable to do a posterior trocar. They're very uncomfortable doing a posterior trocar, especially if you take in the US or the developed countries. They really don't want to use a posterior trocar. So for in those scenarios where you don't actually have to go and visualize the trocar from behind, it's easier to do it. I'm very comfortable in doing both. So I decide based on case to case. So if you saw my first case, I did it with a trocar AC maintainer. And if you see my second case, I went posteriorly because I know I anyways have to go and posteriorly take that intraocular lens from the retina.
And
So
all of these, in all of these cases have been previously vitrectomized?
The first case was vitrectomized. I mean, the second case was already vitrectomized earlier.
And the first case, no.
The first case, I had to do it.
I have to do it.
An anterior vitrectomy. I don't really need
only
to
anterior vitrectomy.
Just an anterior. I'm not going
Because
anywhere.
the problem is that if you put the posterior trocar in, you do vitrectomy, you open the anterior chamber, you say, oh, I'm going to do an anterior vitrectomy. No, because the vitreous with all of the fluid will come to your anterior chamber. You know, and be careful with that.
Yeah.
Okay, I have another question, Dr. Ashpan. What was the reason for drop IOL in second case?
So as I said before, the second case was one of my first few cases of glued, and the white to white, the horizontal white to white, if you look at that, was a 13 millimeter eye. And before, when we never calculated that 12 and 13 millimeter, anything above 12 millimeters, please go make it vertical or oblique, the flaps. Do not make it horizontal, because then the externalization which you get will be very short. You want the externalized haptic to be at least 1.5 to 2 millimeters. And that's what you want to tuck into the Gabor-Chariot's tunnel.
This is the second question, actually, because we have one question. What is the gauge of needle you use for the tunnel in glued IOL?
Okay. So the tunnel, I use a 26 gauge needle. So there are 2 needles I use. One is for the sclerotomy. The sclerotomy, I use a 23 or a 24 gauge needle, depending on the vitrector size. For the Gabor-Chariot's tunnel, I use a 26 gauge needle.
Okay, do you use active or passive suction for picking the IOL from the posterior segment?
It's an active suction. I use full-on active. It's like how you use an extrusion flute needle, extrusion cannula, full-on. Nothing, no difference.
Okay. And how much of haptic do you tuck inside the scleral tunnel?
Equal distance. If you have your flaps 180 degrees, and your sclerotomy is 180 degrees, equal distance on both sides, I would say. So if you get, otherwise you're going to have decentration. If you're going to have one side 1 millimeter, the other side 2, you're going to have a decentered IOL itself. So if you want to have both, equal distance, but averagely 1.5 to 2 millimeters on each side should be tucked in.
1.5. What is the minimum?
1.5, one at least.
One.
One.
Is this method is versus Yamani method? How do you look to it?
So I think both are phenomenal because both of them give me one major thing that the patient will never get with any other procedure. That is lack of pseudophacodonosis. The pseudophacodonosis is basically once you have placed an intraocular lens in any format, after the head shakes, that lens will little bit dangle, especially if you have any ACIOL, iris suture, or a scleral fixated with suture. If you fix with suture, how much ever you tighten that shoelace, it is going to loosen up a little bit. Unfortunately, this is a fact of life. And what happens because of that loosening is that lens will shake after the head shakes. And that does not give the patient clear vision. What happens with Glute and Yamane is that the patient, even if the head is moving, the IOL is stable and the head, IOL is moving with the eye. And this is the biggest advantage for patient perspective. From a surgeon
Yeah,
perspective,
also the opinion of Dr. Safwan, but when he will present his topic,
The
because
issue is that he's right, Dr. Mohammed. He's right absolutely when the suture is polyproline, but when the suture is Goretex,
let
no.
us wait until we present so we can debate them. What cartridge you use for the 3 pieces IOL?
what cartridge do I use for 3-piece? It's the
Yeah.
same sensor IOL. I use a sensor IOL because I don't have access to the. You're talking about the IOL.
Yeah.
Yeah, I use a sensor IOL or a Technis platform. But in case of if I'm using if I had the choice, I would use a Zeiss CT Lucia 603, which is what I think Brian will talk about a little bit more in his procedure, which has the best undestructible haptics. I mean, that's
We have
how.
another also question. How do you follow angulation when you are doing scleral tunnel? The needle, you are doing the scleral tunnel, the angulation, it is follow the same angulation or just parallel to the limbus?
Parallel to the limbus and go along the haptic.
I mean, yeah, this is also my question also. You want it because the haptic, it will be curved, it will not be straight.
Yeah.
So you are going to make it a little bit angulated or straight.
I go straight. It's okay. It's a little bit of marginal. So there are two things that I find. There are surgeons who also make a tunnel itself. They make a tunnel itself and they just leave the haptic there. Let it be. Let it free. Let it be free. That's one way. But my method is that if you use the smaller the needle, the better it is. The thinner the needle, because you get a more snug fit to that whole haptic tip. And even if you make it a little bit, don't make it in the opposite direction. That's the only thing. Go more towards the as parallel to the limbus as you can, but don't go in the opposite direction, because the opposite direction you're going to kink the haptic itself.
Yeah, it's okay. Maybe the last question, what about pigment dispersion as the lens is so close to the posterior iris surface?
I don't think there's so much pigment dispersion because there's no movement of the lens so much. It's the movement of the iris is there. It depends on case to case. We have not got so much in terms of pigment dispersion or in terms of IOL spikes or glaucoma in these cases. In fact, if you ask me, there are higher chances of sometimes the leaking sclerotomy rather than pigment dispersion in
I
these
think
cases.
this one maybe is due to the position that you select in the beginning, as you say, when you do the
The 0.75.
sclerotomy. Yeah. Okay. This is a question, I think, for Dr. Carlos. Um, One comment for drop 3 pieces IOL. Is it highly advised to use BFC as the haptic can easily create iatrogenic tear or macular injury? Dr. Carlos, if you can.
No, never ever saw a lens making something to the retina. I don't use perfluorocarbon liquid because if you put too much perfluorocarbon liquid, the lens go to the meniscus of the perfluorocarbon liquid. If you put not too much, then you don't do nothing. Then don't use it. As Aspen mentioned before, you know, active aspiration, soft tip cannula, you approximate, aspirate, and the lens comes very, 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 very easily. I never saw any problem falling down.
We have a lot of dear friends, they want to participate with us. I will start with Dr. Abdullah Al-Qahtani. Dr. Abdullah, if you can open the mic for Dr. Abdullah, please. Dr. Abdullah, a retinal surgeon in Saudi Arabia, Jeddah, and he's also doing a lot of Yemeni, I think, techniques. Let's see, Dr. Abdullah.
Hello, Dr. Muhammad.
We'll talk about with us after Dr. Kim Ashban.
No problem. He can give us, then later on he can also comment.
Yeah,
Yes,
he
Abdullah,
can participate again with us because his comment is very valuable.
Thank you very much, dear Muhammad and dear Safadi, all the panelists. It's a pleasure to share with you this comment and maybe wondering and hear the question and comment from you. I will not take a longer time. It was a fascinating presentation, a lot of tricks and a long experience. I have practiced actually the Glute IOL, artisan, also scalar fixation, and I feel that Glute IOL is very stable, even though artisan is easier. But sometimes small tricks is very helpful. For example, when you create the tunnel for the haptics, it's better always to create it before penetrating the eye. So when the contour of the eye is okay, you get a very well shaped tunnel. And sometimes you may need to inject a stain inside that tunnel just not to lose it, because with the escaping fluid from the sclerotomy, it can hide in the tunnel itself. And sometimes you may need to create another one even after you create it before. Yeah. I have practiced in a pediatric patient and it's very, very stable also for them. I think artisan is very easy, very accurate regarding the refraction because the equation is established already. It's true, we have a study for a number of patients for Glute IOL, astigmatism and tilting sometimes, as Dr. Matteo said. And I think scalar fixation has the vibrating effect because it works like an axis. The tunnel with the haptic in it make a very strong stabilization for it. Some people insist to do retinal exam after you put the IOL. I do it actually only for scalar fixation IOL because I know when I'm doing indentation, it's very stable. But I'm not totally agree with Dr. Aspen regarding the looking to the retina, because when you look to the retina without indentation, you see only the posterior pole, but you have to do indentation, which is something I don't advise it when you put the Glute IOL, because sometimes you may dislocate it. It's maybe better to look for the retina after you grasp the IOL and make sure the periphery is okay. This is my comment, and thank you for your valuable presentation and worthy comment.
Thank you, dear Abdullah. Thanks a lot for your sharing your experience with us and your comments. It's a valid points and add to our meetings. We will have now Dr. Ahmed Al-Barqi. Can we have Dr. Ahmed Al-Barqi, please? Dr. Ahmed, if you are with us.
The mic.
Yeah, please. Ahmed,
yes.
can you open the mic?
Yes. Hi. Can you hear me now?
Yeah, we can hear you.
Yeah. Hi, everyone. My dear friends. I hope everything is fine. I just want to comment regarding the using of BFC in three-piece IOL. I agree with Dr. Carlos that what he said that you shouldn't feel it fully because it will go for the meniscus. But sometimes the haptic, if you can hold it and it fell down while you are trying to catch it from at the pupillary plane, and it fall down or this space or this distance, sometimes the haptic it fall down on the macula. And I see one case, it's not common for sure, but I see one of the cases where the retinaus, and one of the retinaus was famous complicated surgery, it happened, and the haptic actually hit the fovea. So post-operatively when do OCT for this patient, he found that there is some disturbance at the level. So my advice, if you don't want to use at least peripheral carbon, just a small bubble to protect in case of the IOL fall down from long distance, or at least some viscoelastic if the eye vitrectomized eye, just to protect the cushioning mechanism of the IOL. That's my own concern, and but it's not common. But if it's happened, it will, it will something disturb you. You'll be upset about this. That's it. Thank you.
Let me make a comment. I
Yes,
agree.
please,
I
go
never
ahead.
saw it. I never saw it, but I may agree with that. Another problem with I forgot to mention to Aspen is that if you are doing this in anterior chamber, no problem. But you put your needle inside and you have bleeding, and sometimes you have bleeding. And if you don't have the cannula to enter in the eye and to remove this bleeding, you are doing your maneuvers, you see the lens, everything is perfect. But the day after you have a vitreous hemorrhage, you won't see anything. And be careful with this. If you see bleeding, some drops flowing down, then be careful with that, because the day after you can have a vitreous hemorrhage.
Yeah, any blood loss anywhere, I mean, it could happen during your trocar, it could happen during your sclerotomies, anything. You can pull an iris and have an iris root tear. Anything can happen. Any sort of bleeding, I mean, be careful, because as what Dr. Carlos is saying, you can have a next day morning vitreous hemorrhage in your hand. Yeah, that's a for sure.
I'd like to make one other comment, if I may.
Yes,
Dr. Aspen uses the needle to create his tunnel to tuck. And I have a limited experience with the glute technique. He makes it look really easy, and it's not always that easy. And I think the previous doctor made a great comment about staining with the ink. I think when you're learning it, you need every leverage as possible. So if you can see it better, I think that's better. Also, if someone like me, he has a needle and he's able to thread the haptic through that needle track, but again, not that easy. Sometimes you can just use a blade, just use a blade, make it flat to the sclera and just go in and out. And even though it's going to be bigger and it might not be as stable immediately post-operatively, it should fibrose and hopefully do okay. But Dr. Ashvin, don't be beguiled by how easily he did that. It's not that easy to do it.
I think that Dr. Mohammed, just one comment, if you don't mind. The issues is that when we are doing the tunnel before entering the lens, that's much better, as Dr. Qahtani said, because the contour of the eye, we will lose it when we will enter the lens. Issues is that when we are doing it in the beginning, we will lose the mark of it. So we need to mark it before as a potential step. Yes, Dr.
Yeah, we have another two friends. They want to talk. Dr. Salim, if he is there. Salim Muhammad, please.
Yeah. Meanwhile, while Dr. Salim is coming in, I think one comment I would like to give every attendee, everybody who's going to try this. I think each of you are going to have your own methods of doing this. I would suggest you to mimic somebody who you really look up to and want to follow, and then start moving into methods that you probably would choose. So for example, Dr. Brian Krim now does a blade, and I think that works brilliantly in his hand. Probably for me, what works may not work for somebody else. So don't go just based on, I have to do it this way. You probably have to find your own niche and your own way of doing any procedure that you have to do. So that's my 2 cents in anything that you want to do.
Excellent. Dr. Salim is there, is ready. Dr. Salim or Dr. Amr Al-Khatib and Hani Mansour. Any one of them is ready, so we can take him. Otherwise, because already Dr. Salim, we are trying to catch him, but he is not there since we start. Dr. Salim?
He's here now, Doc.
Okay, Dr. Salim, go ahead, please. Dr. Salim? We are hearing you. Dr. Salim, if you are there, can you just start, please?
Sorry?
Yeah, Dr. Salim? I don't think he is there, John. Can you check Dr. Amr Al-Khatib? Or Dr. Hani Mansour, any one of them. If not anyone, so we can proceed because we don't want to lose the time. Okay, there is a question, Dr. Ashwin. Here, I will for iridectomy after implantation.
Yes, yes. So in cases you should do an iridectomy, please go ahead and do an iridectomy. Yeah, it definitely helps.
Anyone came, Wayne?
No, Doc.
Okay,
Still waiting
so
for response.
okay, so we can continue please with them until you just receive any one of them. So we will have now Dr. Brian to talk about Yamani technique step by step and also modification. He's a well-known expert in this, and he's also doing his modification and publication about the modification of Yamani technique. Thank you, Dr. Brian, for being with us. Just mute yourself, unmute so you can talk. You are mute until now.
Okay.
Yes.
Okay.
Please. Yes, we are here. We can hear you. Yes.
Sorry, let me. Okay, can you see my slide now?
Yes, please.
Okay, so thank you again for having me, and thank you for the other presenters to giving their talks, and I think they're all excellent, and I'm learning a lot today. And so I'll be talking about my modified techniques for the Yamani. As been discussed, there are some challenges with the technique, and so hopefully these things will make things a little bit easier. Before I talk about that though, again, I don't have any financial interests in the talk. And so for secondary IOL, because that's really the topic that we're going to be discussing, we have to think about a decision tree here. So is there something wrong with the lens? In other words, is a patient having trouble with the particular lens, whether it's just photopsia or refractive surprise, or the patient is not able to tolerate multifocality, or if there's damage to the lens, opacified optic or a damaged optic. And in this case, you'd have to exchange the lens. And hopefully it's an intact bag, but the point is the bag is not the primary offender, it's the IOL. Now, is there something wrong with the lens? No. So then the question in this case, if there's a dislocated lens, is the lens worth saving? Is a patient happy with their multifocal or toric lens? Or is a patient monocular and you want to do as little as possible with surgery, as Dr. Carlos was talking about, you want to do the minimally invasive surgery if possible. And so this is what we'll be discussing. And so if the lens is worth saving, then you have to think about repositioning the lens, whether you're going to do an iris suturing technique or a scleral suturing technique, using Goretex, a glued IOL, or a flange, as been discussed by Dr. Carlos and Dr. Aspen. But if the lens is not worth saving, you have to think about, is there a capsule bag defect? Is the IOL bag complex dislocated, or is the lens and the bag itself causing some type of complication, UGG syndrome, pigment dispersion, CME? And so this is what we're going to be discussing. So in general, these are the 6 broad categories of the different methods to fixate a secondary IOL. And so in my experience, I have not had good success with iris suturing. And it could be because, as Dr. Carlos said, I've been using that technique primarily on 3-piece lenses, and I have had late dislocations. And having him talk about the single-piece lenses being thicker and they don't tend to move, and it made me think, yes, and it's softer, so I could see how suturing that would provide a little bit of cushion. But I've never done that with a single-piece lens, admittedly. So my experience has been not very good with iris suturing. And so, as been discussed with the Glute IOL and the Artisan was talked about briefly. And so I think this Goretex suturing is going to be discussed as well. And then more recently, I think Dr. Sergio Canabrava has been talking about using a Polyproline suture and lassoing it around the haptics, or actually tunneling a needle through the actual edge of the optic and then pulling the suture through it, and then using that as a method to flange into the sclera. So I think this is kind of a newer technique that's available, probably going to be talked about in more detail in the future, but I'll be talking about the Yamane technique and how I do it. And that's the intrascleral haptic flange technique. And so, as most of you may be aware, it was developed by Dr. Shin Yamane, and he won the 2016 grand prize at the ASCRS Film Festival. And it's an intrascleral haptic fixation flange technique using double needles to secure a three-piece lens when there's little to no capsule support. And the reason why it's nice is there's no conjunctival dissection, flaps, or sutures, and you're able to, as long as you do the technique correctly, put it in a closer normal anatomic position. But there are some technical challenges. Threading the haptics is a challenge. Sometimes the haptic can slip when you're trying to position it. Decentration and tilt has been a criticism of the technique. And you can have intraoperative and postoperative complications like any of the techniques if the lens is not put in the proper position. So this is the original technique. My friend Steve Safran does it the classical way. And so let me just show, and he uses Dr. Aspen's marker for his technique. So let me go ahead and show this. So the lens is injected and he places the leading haptic into the angle. He starts on the left side and he tunnels and goes in. And he's going to use microforceps to place the haptic into the needle, releasing the left side, doing the similar technique on the other side. And then through a paracentesis contra-incisionally, he's going to place the haptic into the needle. And he externalizes both haptics simultaneously, as Dr. Yamane does, and cauterizing the tips, creating a small flange, and then repositing the haptic into the sclera.
Doctor, we need here only to show us step by step how it's going on. Is what we exactly want to know. How do you do that?
Yes, I'm gonna get to that. So okay, so let me, yes, thank you. So I will skip this part. I think the basic point is you have to learn how to do other advanced techniques before you try this Yamane technique. There are various resources that you can get as well online or going to various wet labs. And what you need is, if possible, is a C2 Lucia lens because it has strong haptics. If not, the Sensor, the MA60 you can use, but you'd have to use a 27 gauge 1/2-inch needle for those. And you need these various instruments in order to improve your chances for success. And try not to do this in the middle of a complication. That's kind of the worst situation to do it. So if you're going to start the case, I like to sit obliquely, actually, superior-temporal if I'm going to do the surgery. And this helps just to avoid the nose. In my experience, this is the best place. And you want to make a 3mm incision superior-temporally, and then a paracentesis 180 degrees away. And you want to make conjunctival marks in order to get a precise placement of the needle. And you have to make sure the surface is dry. Why? Because if the mark is smudged, it's difficult to visualize. You want to make them round marks. You can use a caliper tip, but I also will take the tip of a BSS cannula and mark it. It makes a very nice, distinct round mark. So we're going to start on the limbus, and then I use an axis ring, or you can even use a cannula to find 180 degrees apart, and then mark 2.5 millimeters posterior to the limbus, and then 2 millimeters adjacent. So the left side is going to be a backward 7 configuration, and the right mark is going to be a backward L configuration.
Brian, just one point here to comment is that you made here 2 paracentesis. Just for the audience, the potential Yamane is 1 paracentesis. Your modification is to create another paracentesis at 6 o'clock, and that's one of the important points that because when the audience, they are, as me, for example, I'm using it, so I know, but the other audience, they are beginning, for example, or beginner, they don't know that these paracentesis, the second one is your modification. Yes,
so the 6 o'clock position, or the contra-incisional paracentesis, is where I'm going to externalize the leading haptic, and that's my modification, and I'll talk about that shortly. Yes, thank you. So as has been discussed earlier, trying to make incisions, placing trocars in a soft eye is very difficult. And so you want to place those more difficult incisions, placing the trocar, tunneling your sclera, do it before you make all of those incisions, because doing that is going to be difficult in a soft eye. And I use an AC maintainer, a 23 gauge, and that's purely because I'm not a vitreoretinal surgeon, and I'm not interested in putting infusion posteriorly because I don't feel comfortable doing that. And you want to have infusion in order to firm up the globe so that you can make your scleral needle tracks. And so this is the other point. Remember, the conjunctiva is a mobile tissue. And so as you're making the scleral pass, if you don't fixate the conjunctiva, that is why you are more vulnerable for decentration or tilt with the Yamane. And so you have to find a way to fixate the conjunctiva so it's not mobile. And so in this case, you can see the left side I'm holding with forceps on the incision, and on the right side I'm holding the trocar with the forceps. And you're trying to maintain the conjunctiva in a fixed neutral position. So that means when you're tunneling 2 millimeters, you're tunneling 2 millimeters. And that when you're 2.5 millimeters posterior to the limbus, you are definitely 2.5 millimeters posterior to the limbus. And this is just a video showing this, illustrating my point. So the trocar is held with forceps to stabilize the eye. And you can see that the conjunctival marks are not being distorted with the needle pass. And so this is very important because if you're moving the globe around and you're trying to make the needle pass, you will not be placing it where the marks are. And so naturally, you're going to have a higher risk for tilt or decentration. And so bending the haptic. When the haptic needle complex is released, the first haptic needle complex is released into the vitreous space. You don't want it to be moving too freely into the posterior segment. And so I like to bend the first needle, which is the right needle for my technique. For Yamane, it's the left needle that's the first one. So that's the first modification, is I do the right side first, and I bend it about 9 millimeters from the tip, about 70 degrees. The second needle, which is the left needle, is going to be a full length needle, and it's going to be bent 70 degrees as well. The needle is bent so the bevel faces the haptic. And so in this case, the right needle is facing towards the trailing haptic, down, and the second needle, the left needle, is facing towards the leading haptic, which is up in the video here, in the slide. And so again, illustrating the bending. The right side needle is the first needle, and it's bent 70 degrees, 9 millimeters from the tip. And you see the bevel is facing towards the approach of the trailing haptic. The left side needle is bent 70 degrees and full length, and the bevel faces the approach of the leading haptic. So why the second haptic should be bent at the hub and not angled like the first one? You see the left needle is fixated already, but look, I bent it fairly close to the tip of the needle. And so as I'm trying to pass the trailing haptic through the right side needle, I'm having significant trouble because the left side needle haptic complex is preventing my ability to pass that right side needle through the trailing haptic. So docking the haptic on the needle. The haptic is curved, but the needle is straight. And so this is why surgeons struggle to thread the haptic into the needle. And so the solution is to dock the haptic on the bevel of the needle first, but do not advance it yet. You want to straighten the haptic against the bevel, and then it should slide easily into the needle. So you can see again on the left side, this left side is the bevel is away from you, and the right side, the bevel is towards you. But you can see the approach of the haptic is almost perpendicular, but as you're able to flatten it, it engages the bevel and it docks it, and you're able to turn the haptic, flatten it out, make it parallel to the needle, and then you can slide it. And so that's essentially what I said here. With the PMMA haptics, definitely, if you are too aggressive with this step, you will bend the haptic, and it's going to be very difficult to fix that problem. And so this step is very important to be very gentle. So here the bevel is up, it's not working. Bevel is towards you, it's not working. Bevel down, but then bevel towards the haptic here. You can dock the haptic towards the bevel, flatten it out, straighten it out, and then you could advance the haptic in the needle. So why is the trailing haptic such a problem? And it's because of this. The trailing haptic needs to be pulled towards the left in order to straighten out the trailing haptic to thread into the right side needle. But if the leading haptic needle complex is intact, as you're trying to move that trailing haptic to the left side, the leading haptic needle complex resists the straightening of the trailing haptic to thread the needle. So you have opposing forces, and that's the reason why it's such a trouble. And you can see that here. Part of the problem is I'm holding the haptic a little bit too far posteriorly, so I don't have very good control. But again, if you're docking the haptic on the bevel, this problem actually is resolved, and I'll show you that. So my modification is the trailing haptic first modification. I think I submitted it in 2018. Whenever I've taught this technique in the wet lab, the original technique, everyone struggles with trailing haptic. But when I show them this modification, they're able to successfully cannulate the trailing haptic without any problems. And so what I'm doing is making the 6 o'clock paracentesis, which is contralateral to the main incision. As the leading haptic is delivered, it is externalized through the contralateral limbal incision. And you can see that it's externalized. And by doing it this way, you're able to fixate the trailing haptic much easier. And what makes it even more easy is place the trailing haptic through the incision in a U-shaped configuration. And then you're able to grasp the apex of the U, and it happens to be the perfect distance of haptic to thread the haptic into the needle. And you can see, even though it's fairly perpendicular, you're able to take advantage of the docking principle, flattening out the haptic on the bevel and then straightening it out. And you can see this here. So the technician is advancing the IOL for me. I'm externalizing the leading haptic with microforceps. You want to sweep the trailing haptic to the right. The trailing haptic is captured within the incision in a U-shaped configuration. The apex of the U is the ideal place to grasp the haptic. Note the bevel of the needle is used to dock the haptic, then straighten, and then advance. The leading haptic is internalized with microforceps and placed into the angle. And then the leading haptic is docked on the bevel of the needle, straightened, and then advanced. The haptic is pulled out in the direction of the needle tract, and forceps are used to push the haptic into the sclera. I try to avoid externalizing too much of the haptic. And then you cauterize the tip, and you do the same thing on the other side. You want to prevent externalizing the haptic too much on the left side, because if you pull too much of the haptic out, that means you're actually potentially pulling the right side haptic out of the needle, potentially. And then you push the haptic tips into the sclera. And so the benefit is externalizing the leading haptic secures the IOL. It makes fixating the trailing haptic very easy. Of course, it does require an assistant to deliver the IOL, and then you do have to internalize the leading haptic as a second step. So this is an additional step to the original technique. So if you can't get the C2 Lucia 602 lens, you are able to do this with the MA60AC or the Sensor, but these haptics are made of PMMA, and so they are much more delicate. You can't use the thin wall 30 gauge needle with those lenses. You have to use a 27 gauge needle. And so I'm going to show you this on a Simulise eye. This is the MA60AC 27 gauge half-inch needle using a Simulise model. So you see the leading haptic is pulled out through the contralateral limbal incision with microforceps. you always want to coat the corneal endothelium once the lens is delivered. The trailing haptic is captured within the incision. The right needle is bent 9 millimeters from tip, placed 2.5 millimeters posterior to the limbus, tunneled 2 millimeters. The haptic is grasped at the apex, flattened out, and then it's threaded into the needle. And then leading haptic is internalized over the iris. The left side needle is placed 2.5 millimeters posterior to the limbus, tunneled 2 millimeters. The haptic is docked on the bevel, straightened and flattened. You can see even though I was grasping the haptic somewhat more proximal, I was able to flatten it out and thread the haptic into the needle. So since I go 2.5 millimeters posterior to the limbus, I do choose a IOL target power of a -1 because it's going to be sitting a little bit more posterior. So you want to make an adjustment for the lens power. And you want to prime the needles with BSS, because when you're placing the needles through the sclera and then it emerges into the vitreous space, you'll see bubbles coming out and it's very disruptive. And you always want to think about patient anatomy whenever you're doing these difficult cases. If you have a lot of corneal distortion, put some BSS or OVD on the cornea to help your view. And remember to place a peripheral iridectomy at the end of the case. As far as why not cauterize the first haptic, some people think, oh, I'm going to pull out the one haptic, cauterize it, and then do the other side. Well, the problem is if you, let's say on the left side haptic, you cauterize it. Well, now it's anchored to the scleral wall. And so when you're trying to retrieve the trailing haptic and you're trying to fixate it through the needle, the left side haptic is anchored to the scleral wall and it fights you. Again, those opposing forces make it difficult to straighten the trailing haptic to thread the needle. So you can see that here. This is, again, my mistake. This is when I was first experimenting with the technique. And as I've discovered, like others I'm sure have, this is the fastest way to either break the haptic or just create a lot of frustration. And this is a situation once I've externalized both haptics and I pushed it down, I noticed that the lens is a little bit decentered. And so I'm trying to find the haptic, but you know, I've buried it past conjunctiva, past tenons, and I'm getting all this bleeding. So this is a tip. You can take the same needle and you can just go right underneath the flange and pull it right up. It was just so easy. And so use the needle that you use to dock and you can pull it up, cut it, and then I was able to reposition it. It's a much better position here. Well, sometimes it's not that easy, and it's because the lens is decentered because you just didn't have a good approach with your scleral needle track. So sometimes you have to pull it out and then go back in with microforceps and pull the haptic all the way into the vitreous space. You want to place it on top of the iris and then retunnel. Once you realize where you made your mistake, retunnel, grasp the haptic, dock it on the bevel of the needle, flatten it out, and then advance it. You want to pull it out again in the direction of the original scleral track, and then you want to push the haptic flush to the sclera and have a better centered lens here. And so there are many nuances and technical challenges to this technique, but I do feel the techniques and modifications that I've developed over the years do help me flatten out the learning curve, and I do hope that this will be helpful to you as well. Thank you for your attention.
Thank you, Dr. Brian, for this very excellent presentation and showing us how we can use the technique of Hani for secondary oil implantation and your modification you have done. Just there is many questions, but before that, I want just to clarify some points. You are doing one sclera, I mean, you are doing a corneal also at 6 o'clock. That's one used only to pull the haptics and to prevent from falling down in the vitreous, for example, and to fix it, right? Is the aim important?
Correct.
But this is the first. So just to clarify this point. So I didn't get your point from why you are doing two I mean, in each side two landmark, and then to what is the aim of that? I didn't get the idea of that.
Can you repeat that question? I didn't understand.
2 millimeter by 2 millimeter.
2 millimeters.
Oh.
Why you are 2 millimeter by 2 millimeters?
Okay, so you know, one of the criticisms of the Yamani technique is that you have decentration or tilt, and my opinion is that the people who are doing the Yamani technique are not tunneling through the sclera 2 millimeters, because you want to recreate what the glute IOL technique is, or the Sharioff technique, because you want, as Dr. Carlos mentioned before too, is you want a shelf of sclera where the haptic is sitting. And by having more of a scleral shelf, a horizontal shelf, that lens is less likely to be tilted. What I've noticed is people, when they just go in, they don't even make a tunnel. Some people just go in, straight in. And then if you do that, the haptic will sag vertically. You need a little bit of scleral shelf for that haptic to go in. And so you want to go 2.5 millimeters posterior, because I worry about iris chafe. But then that adjacent mark of the 2 millimeters is simply because I want 2 millimeters of sclera for the haptic to be supported.
Okay, do you mean by that when you are doing the getting the haptics, you will put it from the first landmark, then you go inside the other one to the other points, the 2 millimeters. Did you take the haptics from the first point, then you put it inside that tunnel you created at 2 millimeters apart, so you will be sure that it will be there, or you do
That's right. Yeah, I want to give myself some confidence that I have 2 millimeters of sclera before I get into the vitreous.
Brian,
yes.
Let me ask you one thing, because from a theoretical point of view, it's clear that what you were mentioned, but imagine the eye, many of these eyes, the pupil is not that big. And then when you make the 2 millimeters, then you go down because you have to see it. Then you break the scleral fibers. Then, you know, I think it's very important, the tunnel, but, you know, at the end you break it. Have you considered any time to put iris retractors? Because with iris retractors, perhaps you can do until 3 millimeters, and then you put the, you know, okay, but, you know, the tunnel is very important, but I see many times that I enter 2 millimeters, perfect, almost 3 millimeters, then you make, you know, 90 degrees to the center of the eye, then you break the scleral fibers. And, you know, the tunnel is not so clear.
So I have one comment on that. I think that actually, in my experience, the longer you make the tunnel, the worse it is, because when you try to make too long, then you really turn it, you are going to break the scleral fibers. But I don't know if you noticed on my video, when I turn the needle, I don't turn the needle all the way to the center. I stay more proximal where the haptic is. So again, the trailing haptic, when I turned it, I kept it fairly close, and then the same with the leading haptic. And the reason I'm able to do that, and I've done this in small pupils without retraction or, you know, iris hooks or anything, and it's because I'm able to have such control of the haptic and guide it into the needle. I think a lot of people don't articulate how difficult that is, and you know, it's not so simple. But if you have the way I do it consistently by docking it on the bevel of the needle, I haven't really struggled at all. And so you're able to do it fairly easy. You can see it, you grab it, you flatten it, slide it, and you're good to go.
We do the same, and I like that you make the same as, you know, the first, you know, haptic is a superior haptic. I love it. I didn't know.
Yeah,
it.
you did that. That's right. You did the same. So yeah, that's great.
For integral, I do this absolutely the same. It's by far better. Yes. It was very clear.
Just one comment, Carlos. I do agree with you. In the beginning, when I start, I was in need to use the iris hook to see my position, but I never went 3 millimeter in the tunnel.
No. I was telling 3 millimeters.
Yeah, just 4. As Brian said, that if you will go to the center, if you will direct the bevel, which is in front of the haptics, and you direct it toward the center, 100% you you will create a rupture in the scleral fibers. But it's not. It's only toward the direction of the haptics. So it will go through less than 40 or 35 or 25 angles. So this is the way how to protect the tunnel. And the way that you protect the tunnel, the better that you have a flattening of the lens.
Of course, absolutely, I agree, totally.
Okay.
We are having many questions, but maybe I will keep this question till the end so we can have Dr. Safwan first, because so many questions, it will be, I think, so let's have Dr. Safwan on his presentation.
Okay.
Then we can have all this question.
So good evening for everyone, and I will go through and share my experience in dealing with the secondary IOL. As I said, good evening for everyone, and I need to thank Dr. Mohammed Al-Amri always to having me with this nice, eminent speakers, and I need to thank all the speakers and all the three of them, because they share with us their experience, and hopefully that we will be of benefit to give the audience all the points and tricks how to use all the details for the secondary IOL. So secondary IOL implantation, as we know, and as is being discussed, it's not an usual cataract surgery, complicated cataract surgery where there's no support for the lens, sulcus or in the back. Dislocated intraocular lens, as is being discussed, with the capsular back complex, congenital or acquired dislocated human lens. So this is the indication. And if we will go to the scleral fixation of posterior chamber IOL, can be an effective approach using polytetrafluoroethylene, as Dr. Carlos mentioned, which is the Goretex. And this suture, I searched for the one that he used it off-label, and the first one that he published few things around it, Professor Richard Hoofman. It was hypothesized that 4-point fixation IOL would allow excellent IOL stabilization, while the Goretex material might reduce the concern regarding suture break encountered with a polyproline suture. Now, the technique could easily be paired with either PPV infusion cannula or the anterior AC maintainers. I think that for the anterior segment surgeons, as Dr. Brian Kim said, that they are more user for the anterior AC maintainers. For the posterior surgeons, posterior vitreoretinal surgeons, they prefer infusion cannula. Now, each one having his explanation. For someone poor like me, in between both, well, I'm using both, but I prefer to go through according to the condition. Now, scleral fixation versus other treatment options, it's very difficult with the pioneer surgeons to say that, well, this technique is better than the others, especially I'm using other technique. But when we are comparing iris fixation to the scleral fixation and sutureless scleral fixation, glued IOL, anterior chamber IOL, and Yamani, well, in my technique, why I using the scleral fixation with the glued, it include relative easy of insertion and fixation. Use of small corneal incision, as what we will see, and even in Yamani, we use a small, even in a glued. Avoidance of iris contact and theoretically a lower risk of dislocation and pigment dispersion glaucoma. No scleral flap need with the Goretex suture, but conjunctival peritomy is needed in reverse to a Yamani, where we don't need any conjunctival peritomy. Now, if we will go to technique, I will discuss it in detail later on the movie, but a few points that I put it. Mark corneal limbus, which is at 180, it means that 3 and 9. Nasal and temporal conjunctival peritomy. Well, I didn't face any trouble with the nose of the patient. Maybe the nose of our patient, they are small comparing to the others. A standard infusion line for PPV is installed, or AC maintainer. As I said, the anterior chamber is entered through a clear conjunctival corneal incision, usually 2.2 for me. 7, the Goretex suture is cut into halves. Needle should be removed. Means that I will not use a needle here. And I'm using Physiol hydrophobic, or theoretically we can use the Aquarius, as Carlos said, which is hydrophilic, but I don't prefer it. With the 4 eyelets, the idea is 4 eyelets. Now I know that Carlos now he has a lot of comments on what I'm saying, but anyway, the Physiol hydrophobic, I feel that it's very easy to use and less complication. The lens is injected into the AC. Once in the eye are rotated into the AC in a way that their eyelets will be toward 3 and 9 o'clock. Each end of suture can be grasped and externalized through the respective sclerotomy using the max grip Alcon or similar serrated forceps gauge 23 or 25. All 4 ends of the Goretex suture are then pulled, and tension is balanced to ensure that the IOL is well centered, and always this IOL is centered. The trocar are removed, and then the whole surgery will be ended. Now, if we go to the surgery, here I will try to grasp and see. Now here, in this case, I use the vitrectomy because the case was presented with the cataract complication and lens matter was in. So I use the 3-pore entry. And I will go through slowly here, just to show a few tips. When I pass the trocar here, the trocar, the 3 trocars, the temporal one, the infusion, and the upper one, it was a little bit away from the other, leaving the area for 3 o'clock to be peritomized here. So I did my peritomy, and here cauterize the landmark for 180, 3, and 9. It's very clear here on the cornea. And then when I the landmark for sclerotomy, it will be 2 millimeter from the limbus. This point is 2 millimeter. I think that all of us, we are seeing my arrows. 2 millimeter from the limbus and 3 millimeter apart. If I will return back a little bit, here, those points, this is a limbal, 3 o'clock, and this is 9 o'clock. And this point is 2 millimeter from the limbus, 3 millimeter apart between them. I hope that everyone is seeing my arrows. Dr. Mohammed, you are seeing my arrows?
Yes, Dr. Safan. Yeah, Dr. Safan. It's very clear, very clear.
Okay, so I will continue step by step. So here, when I prepared everything, and I will go to finish my duty inside the eye, where I removed all the lens material and return back. Now, here in this step, I will go to MVR and open the sclerotomy sites here. Each one, make sure that I'm in, tip in, and then I will test my gauge 23 forceps. See, this is the gauge 23, either serrated or tying forceps, and then implant the lens. Very clear. I'm using the usual injector, the injector for the Physiol, or any injector that can suitable for this lens. 2.2, lens in, vertical on the iris, then rotating the lens. When we are up to 3 o'clock, you can see the 2 haptics here. This is the eyelid, sorry, the 2 eyelids, and here the 2 eyelids, and then rotate the eyelids toward the side for the fixation. So it will be 3 and 9. Now, the important step here is that preparing the suture. You can see my left hand and right hand is working. Left hand holding the suture from one side, and the right hand holding the tying forceps from the other side, from the sclerotomy side, going through the outlet, the eyelets of the lens, one, grasping the suture out, externalize the suture, and then the left hand goes back to hold the other end, and See that the other end is grasped, and then my right hand again through the other sclerotomy side, through the other eyelids, grasping the other suture. It's very clear here. I'm very slowly in and getting out. Now, what we have a loop around the two eyelids. And we will repeat it for the other side. It's very simple. Now, just grasping the lens toward the side, I will repeat the movies again. And again, the first suture, it should be taken, the tying forceps through the eyelids, and then grasping the suture, the tip will appear. Now, yes, it's grasp the suture. This is the first one outside, and then we will go to the second, and then through the other eyelids, taking the suture out, externalizing it, and we have another loop. Now, we have two loops here, and the four eyelids over the iris. Easily to push it back to the iris, so it will be back here safely. There's no touch, no need for a measurement. Here, the other two eyelids in, and now we finished. The lens, if you can see, it's centralized. Now, with the simple, gentle tension on the suture, it's centered, and then now the tying. 1, 2, 3, and then that's all. We don't need to create any tension. So that's why here I need to stop, because Aspen mentioned one thing related to the mobility of the lens, and when the human being turn his head, the lens will move with it. I don't think so that it's true with the Goretex suture. So I can finish here tying, and then cut all the sutures, cut the trimming it, and buried it both, and then close the conjunctiva. Now, I think that I have the right to return it back, and it will be now with a quick, it's a very quick movie. And you can see the tips that I mentioned it. This is a vitrectomy. We can skip for this side, and you can see the sclerotomy, sorry, the peritomy. The marker is very clear on 3 and 9. 2 millimeter away, 2 millimeter from the limbus, 3 millimeter away from each sclerotomy here. Now, MVR through the sclerotomy to prepare it. I'm seeing the end of it for each. And then the main incision is open. It's 2.2. Testing my grasping forceps or micro tying forceps, implanting the lens on the iris, rotating the lens toward the 3 and 9. Here, we will start with the right or left according to the surgeon's preferral, grasping the one end from the left and right, grasping the micro tying, go through the sclerotomy side, then the tip through the eyelids, grasping it out, externalize the one side. There is no jam of the suture inside the eye. Or other surgeons, they prefer to put the sutures for the lens externally. I don't like it, because when we will implant the lens, there will be a jam of suture. Here, you don't have any jam. See, you can take it, externalize it, and the loop is in. And then other things, the other side is the same. I'll just make the movie faster. Take the one tip from the eyelids and then go through the other sclerotomy, the other tip. Here, grasping the second tip through, see, by right hand, I can prepare the eyelids for the left hand forceps and grasping the suture outside, and then we will end up with the suturing of two ends, 1, 2, 3, tie knots, and then trimming the suture and buried the suture, and then close the conjunctiva. Now, That's what Dr. Aspen discussed, and it's very clear. The issues is that how it's in reverse to scalar fixation. There's no tunnel, and I'm just fixing the four eyelids in a horizontal way, so the chance of the tilt is very low, is a minimal in this technique. And again, for the Hani, I'm using the Hani, and I will show you tips that my technique to not to use double needle. Now, Dr. Brian, he mentioned all the issues, a modification on double needle. The double needle, it wasn't the potential steps. Yamani, when he created first surgery, it wasn't with the double needle, but because of the complication and because the one side of the haptics is not cauterized, so we will lose that haptics in, or we will lose the lens. He create the double needle. Now I will go to that's the hinge. I will go to the movie without double needle. Now this lens is being in, and I decide to skew that lens and rescue that lens, and that's the movie how it's work. Here I'm doing the paracentesis. The marker, the lens, I get it up, and it wasn't prepared for the record, so I'm just releasing the haptics from the bag, and then releasing the trailer haptics. I did my vitrectomy. The pupil is small here, so I was scared to touch the pupil, but in one step I used the retractor. But you can see, I return back to recentering the lens. The leading haptics was up. Marker was 2 millimeters. See, but here 2 millimeter, and then 2 millimeter. So I used 2 by 2, but it wasn't clear. Unfortunately, the camera was in the center. Here I used 9, not 9 and around 10, or sorry, 11. No, I used 9 for both. And I used the old technique, the leader haptics first.
Can you stop one more? Can you stop
Yes.
the video? Look at this range, what I mentioned before. Oh no.
Yeah, I do agree with you. I will go back to the movie and I will stop it.
And you see the the syringe and the needle. You have a small iris. To see it, you have to 90 degrees to gyrate, 90 degrees the needle. Then you can, the sclera, the tunnel is not that good. It happens to me. It's difficult to maintain a good tunnel when you have a small pupil. It's very difficult.
Yeah, I do agree with you. Just if you lead me to finish the movie, then you will see at the end for the second haptics, I use the tracker. I use the iris retractor. So just let me go through. Unfortunately, yeah, I think that I reached to this state. So
can you forward, Safwan? Can you forward? Yeah.
Sorry, sir.
Try to forward the movie.
You, Muhammad.
Can you forward the movie, please?
Yeah, it is. I'm forwarding the issues, but because there is a point in it. So here, see the tunnel. The tunnel is clear that I'm using this tunnel, and I tried to put it. This is, as I said, that this is the beginning. See, I'm trying not to be toward the center, and I'm trying toward the periphery. This lens is in, but now I'm using the modified for brain chem. But here, I didn't use the double needle. See, I getting the haptics outside, and I did my hinge. I'm using the old cautery here. See, the hinge was fine. I push it in a way that I feel that it's now stable. Here I use the iris tractor. So I do agree with you, because I felt that, well, the handling of the right, it will be difficult. So I went through the tunnel, so you can see that the tunnel is fine. And here, Yes, the step that makes me succeed is that I went through near to the end of the haptics. I get it out, and I didn't create attention to the other haptics. See? And then hinge again. I remove the retractor, it's centered. And this is the second day. So here, I just need to go through and, sorry, I have, that's my screen is not, yeah, it's not escape. So my screen is locked in a way that, oh, okay. I think that, as Brian Kim said, that Simul Eye as a teaching site is the best issues for all beginners to use, and that's this is a Simul Eye, and it shows that the marker on it, and it's very helpful for someone that is starting the Yamani technique, and he can do whatever he needs. Now, for me personally, I'm using now the modified Brian Kim, but sometimes with the double needle, most of the times without double needle. Okay. And I think that we go through all these steps. So I will let the questionnaires and audience to have their questions, and then we can answer whatever you need, Dr. Muhammad.
Thank you, Dr. Safwan. Thanks a lot for this very excellent.
Let me tell you something.
Showing the scleral patient. Yeah.
You show a wonderful technique using the Goretex, wonderful. You know, if you have the lens in, use the lens in, because it's by far more simple than put the lens in. You know, it's by far more simple.
That's why, Carlos, I didn't show the lens in. Now, let me just tell you one thing for the complex in. Now, if the complex in, my technique will be different, because the suturing site will not be horizontal. The suturing site will be vertical. Because if you will suturing lens in and your suturing site was horizontal, the lens will tilt. So what I'm doing in a complex, because taking time, I didn't show everything. So when we have a complex, for example, that complex having hydrophobic, let us say Alcon lens. Here, when we are suturing this lens, the sclerotomy site should be vertical, not horizontal. So as it's, I'm doing slits in the sclera and putting the suture vertically, because if you will put it horizontally, the lens will tilt. That's one tip that I need to talk to you about.
Yes.
No, I was telling you that
Acreos
lens inside.
Yeah.
Using the same technique I showed is by far more simple.
Rescue this lens. Don't worry. I'm rescuing it.
Okay. Anyway,
can in my hand hydrophobic? Definitely, I will use the hydrophobic one. Yeah.
Can we have Dr. Kim, please? Can we have Dr. Brian, please? Can go ahead.
I was going to say, can I show you just a brief video of me doing the Yamani in a small pupil? Is that okay?
Of course.
Yeah, you prepare it till we get Dr. Khalid, Dr. John. Yeah.
Here it is. It's right here.
Prepare the video, please. Dr. Khalid Abdeen, if he want to talk. Mr. John.
Can you see this?
Not share yet. Can you share it, Dr.
So I will stop. I should stop sharing.
You already stopped sharing.
Oh, okay. Sorry.
You stop sharing? Okay. So let me pull up my video. It's narrated, so I apologize.
Dr. Ahmed Al-Barqi, also if he's there, or Dr. Khalid. Mr. John, open for any one of them. After that, we'll have a question, because we have a question. I need also to have one small talk by Dr. Mina. Okay.
Do you see my slide in front of you?
Yeah. Can you open the
small pupil Yamani? Yeah, you can.
Okay. Here. Just go ahead, and I want to just show you this real briefly. Okay.
Okay. Go ahead, please. John, can you prepare Dr. Ahmed or Dr. Khalid if anyone of them is there after Dr. Brian.
We see your screen, but we don't see the video.
Video is not open, Dr. Brian.
Oh. Okay, let me try again.
Okay.
So I'm going to share screen.
Yeah, go ahead. Dr. Safwan, we have questions for you. Till Dr. Brian also ready. Or this one for Matthew. Dr. Matthew, any cystoid macular edema following iris fixation IOL? Dr. Carlos? No, you have to mute. You have to mute.
Of course, but all the techniques have shown the similar ratio of cystic macular edema.
Yes.
Then, you know, all the techniques can have cystic macular edema. I had it. Yes. But with medical treatment, all of them disappear. But, you know, all of these techniques may have cystic macular edema.
I fully agree with Dr. Carlos.
For Dr. Brian, can you get, because we are almost behind the time, so we can get a very short answer.
I'm going to show it. Tell me if you see it or not. Here it comes.
Okay.
Is it coming?
No. Still we are seeing the screen.
Okay, can you have answer the question and keep the movie?
Brian, open a PowerPoint and put it inside, and then share your screen.
Okay. Yeah, give me one moment then. Give me one moment.
So let us go to this question.
Yeah, we have some question, Dr. Brian. What is the length of the haptic you inserted inside the needle?
It's a C2 Lucia 602 lens.
No, the length of the
haptic.
Half the length of the haptic.
Half of the length of the haptic you inserted inside the needle. Okay.
Yeah.
Okay, there is another one. What is the gauge needle you are using for docking IOL by, Dr. Kim?
30 gauge, half-inch thin wall needle.
Okay, 30 gauge. Okay, you can prepare till we get. What type of micro forceps do you use?
MST microforceps.
MST.
Yeah, yes. MST Alcon or the gauge 23 tying forceps.
Okay. Risk of endophthalmitis in this technique without risk of endophthalmitis.
I have not had a single case of endophthalmitis.
Any experience?
I didn't have any.
Dr. Carlos, any comment of endophthalmitis about these techniques?
No, I haven't had any case of endophthalmitis just to now. I don't know in the future. But
now, when we are saying here, Dr. Muhammad, just one minute if you don't mind. When we are saying here endophthalmitis here, why we are separating from the cataract surgery? What's the difference? I'm not seeing that. I don't know whether Carlos agree with me and Brian Kim. There's no difference here between cataract surgery usual and the secondary IOL implantation. It's an implantation, but we are going out and in. So I think that the rate, it will be the same.
Safwan, perhaps they refer to, you know, the haptic in the sclera has a channel for the infection to enter in the eye.
Yeah, but it's covered by the conjunctiva anyway.
Yeah.
Right.
Okay. Anyway, Dr. Kim, how to decide how much to cauterize? And what's the cauterization? How
just a small amount to create a small little bulb. You just want to prevent the haptic from going through the sclera.
It's about 1 to 1.5 millim. If you need to measure it to create a hinge, it's around 1 to 1.5 millim.
Okay.
No, we are talking about the cauterization.
Yes. Yeah, by cauterization. I measure it and I put a mark for it. Okay. So I reach to 1.5 millim, then the hinge is between 1 to 1.5 millim, the hinge will be resistant to the sclerotomy tunnel.
Okay, there is a comment, the 2 millimeter tunnel is made blindly through the sclera. Depending on experience, or there is anything, I mean, you can go, like when you are doing in case of strabismus or something like that, or what is the way that you are thinking you are deep, how deep you are going to be in the tunnel? And
you know, that's just with experience, but I think I've seen some videos where doctors have been marking with the ink pen 2 millimeters from the tip of the needle. My only concern with that is, you know, putting that ink into the vitreous space. But the few surgeons I talked to who did that said they didn't have any complications. So I think it's not a bad idea to ink it, but my warning would be to make sure that the ink is dry before you place it into the vitreous space.
Okay, how do you prevent the first needle from moving inside the eye while manipulating the second needle?
So, you know, the first needle is bent 9 millimeters from the tip. So when you release the haptic in the needle, it doesn't move too much. It stays right where it should be, mainly because you bent that needle. So that needle doesn't have a very large excursion into the vitreous space. It hasn't been a problem in my experience.
Muhammad, just one comment here, because Muhammad,
yes.
just one comment if you don't mind. Now here we have two sides of needle. The double needle technique is the modification. Yamani did it. And the two sides needle, I think that 9 by 12, the first should be 9 and the second should be 12. 9 because any rotation will not touch. That's the proposed for that it will not touch. So as a vitreoretinal surgeon and anterior segment, I went in and I saw it. It's not touch. It's in the mid of the vitreous. The issues is that it will reduce the tension of the haptics and gives you more spaces to work for the let us say trailer haptics. But
okay,
when
we have money.
If you don't mind, just 1 minute. If you are taking the haptics, the trailer haptics, and press it down more, you might touch the retina. So here, with the experience, you will not do it. But still, there is a risk when you are pulling the trailer haptic more and putting down. Yes, Mohammed. Thank you.
Okay, please. Now I can. If you are ready, Dr. Brian, for
yes.
maybe it's okay.
Yeah.
Okay.
Can you see my screen now?
Yes.
Yeah, we can see.
Okay, here we go. Hopefully.
Is this the one?
Yes.
Brian, if you want to comment while the moving is working.
Oh, can you? So now, you know, I put the trailing haptic first. Can you hear the narration or no?
Yeah. I can hear you very well.
Can you stop it, Brian? Okay. Look at the angle. Look at your marks. Oh,
sorry.
It's okay. It's okay. It's coming. It will come.
Okay, I think we can go for Mr. Dr. Ashraf. Then we can find. Okay.
Look at this now. Look at this. You go perfect. This is perfect, but then a little bit further, a little bit more. Okay. Look at this. This is the same problem. The same thing. You know. Look at this. Now take a straight line between this and the end of the needle. You know, it's not the same. You have 3 points here. Then the tunnel breaks. This is my main problem. This is great, but you know, it's my main problem is that you make 2 millimeters, but at the end you break the scleral fibers in small pupils. Then the lens is perfect. The lens you use is this Lucia, right?
Yes.
Yeah, this is perfect. Absolutely perfect.
So let's just see how this case goes as far as being able to pass the haptic in the needle.
Why is moving slowly? Can it move normally, please? Brian, you can hear me?
Yes.
Okay.
Brian, can I ask you one thing?
Yes.
Why I insist in one optic first and then the other optic first, only one needle, because now you have part of the elasticity of the first optic is inside the needle. then there is no elasticity. Is very, is in the needle. Then
Right.
you lose this, elasticity of the first haptic. And then this Lucia is perfect to do this. But in other lenses, you can break the haptic doing this. I saw it in some cases.
Yes.
Right, right. Well, I mean, right now, I'm not applying too much tension, and you saw with this Simulize eye, you're right. I mean, there are more risk factors, definitely, when you try to use excessive force on those PMMA haptics. I agree.
Oh, great.
Yes, see the bubble is toward the haptics. See, Carlos, why I'm using only one needle. The issues is that at the end, the amount of the cauterization is, as I told you, that to create the hinge is 1 to 1.5 millim. That's why I said, as far as the hinge, I'm creating it at the end is the same, so it doesn't affect the centralization of the lens. But the issues is that Kim explain it in a better way, is that the tension that we might in the beginning, as I say, in the beginning, we might create a tension that will draw the haptics through the scleral tunnel. And that's why in the beginning, Kim, he drew it again to recenter the lens. That's my opinion. So with the time, I don't think so that we will be in need for a double needle technique.
Let us see now, Doctor, thank you for all of you. Now we can have Dr. Ahmed Al-Barqi. If he is ready, can you just have Ahmed Al-Barqi comment?
Hello?
Yeah, Dr. Ahmed, we are with
Can
you.
you hear me? Okay, thank you, Dr. Mohammed. First of all, I want to thank all the speakers actually for excellent presentation and videos and technique. I just have one comment and two questions for the panelists. Okay. I like to hear the feedback about that. The first comment, I want to say that because, this secondary implementation usually is one of the topic in any retina meeting. So there is a lot of debate, a lot of techniques. And there are many factors that have impact on decision making while decide which technique you use. For me, I believe that the most important decision making factor is surgeon experience. Because, as you see, different technique, different tips, different tricks. So, and the number of cases is not that high that you build up a learning curve, unless if you are working in a tertiary hospital with a lot of cases to build up your learning and teaching. So I believe the best technique is the one you are mastering and you did a lot and you know all the tips of the tricks. And you see from all my colleagues, any small mistake, even from the marking, especially the marking or starting with the marking until holding the haptic, it might lead at the end of the surgery, after all this effort, difficult surgery, not good outcome because of the tilting or astigmatism. So it's not that easy surgery to do. It seems surgery because we have expert surgeon, but it's not the truth in real life. So my advice is...
We have mentioned this in the beginning, Dr. Ashton.
Yeah, I missed that because I know what is very important, because another point is, I think the best or the safest technique will came when the company designed, especially made IOL for secondary implantation or scale fixture, because the haptic we are dealing with in Yamani technique or Endeavor or glued IOL, this haptic is not designed originally to be bent and hold and inserted in a needle or something like that. And I have many cases, I've seen many cases with expert surgeon, during the second haptic, it's break. And it was very frustrated because, we have to repeat everything again. So it's not that easy. I think the safest technique will come up when the company, it's difficult, by the way, I discussed with the company, they said it's not economically wise to do that because it's not too much cases. We cannot design, especially haptic with, in terms of material and memory. My question to the panelists, because it was also raised in one of the meetings.
Can you send this question by sending only in a question? Because
no, it's very simple. Did the secondary anterior chamber IOL is now contraindication in all cases? Should abandon this? And the second question, what about the knit technique? Have anybody net technique. Net technique, using the Proline suture as a retention suture, the one we're using sometimes to prevent the silicone oil to come out in aphakia. There are one technique called net technique that we published in 2017. I think it was using the retention Proline suture as an artificial bag, let's say that, and he put the IOL on top of this.
Okay,
For term of centration, it will be more. That's my thought. Thank you so much.
thank you very much, Ahmed. I will not answer the question now for the time being. For the sake of the time, we will now have Dr. Ashraf. He will give his presentation. Then after that, we will go or question finally, if you don't mind. Please, Dr. Ashraf, sorry for delaying you. Please go ahead and give your talks.
It's okay. Thank you very much, Dr. Mohammed. It's a pleasure to be here. My name is Mina Ashraf, Marketing Director, Middle East at Lunatus. So on behalf of Bausch & Lomb and Lunatus, we would love to thank you very much for giving us the chance to sponsor this meeting. And also thank you to all the attendees for their presence. Today I will briefly introduce to you Eyelid. Eyelid is actually our newest introduction in the Middle East markets. Eyelid is an anti-infective and a corticosteroid combination. Eyelid is tobramycin 0.3% in addition to loteprednol 0.5%. So as you all know very well, the Lotimax suspension and the Lotimax gel. Now Eyelid is actually Lotimax in addition to tobramycin 0.3%. Talking about Eyelid, it's worth mentioning that ocular inflammatory diseases impose a significant medical and economic burden on the global society. Ocular inflammations is one of the leading causes of eye disease worldwide, accounting for 10 to 15% of vision loss in the United States of America alone. And there are several ocular inflammatory conditions for which a corticosteroid therapy may be indicated. And in addition, there is a risk of superficial bacterial infection that may exist. And these conditions include ocular surface infection, inflammatory diseases, some forms of conjunctivitis, superficial ocular surface injuries. So inflammatory conditions of the anterior segment of the eye that need this combination of corticosteroid therapy, and there is a risk of bacterial superficial infection. Oftenly, these conditions are treated with combination eye drops that contain both a corticosteroid and an antibiotic. Eyelid is a combination of the ester corticosteroid loteprednol etabonate in addition to the broad-spectrum antibiotic tobramycin. So Eyelid includes basically the innovative ocular corticosteroid loteprednol etabonate, which was designed specifically for ophthalmic use. And loteprednol, as we will see in the coming slides, it provides quick transformation into inactive metabolites upon instillation, favorable toxicity profile, reduced propensity for elevation of intraocular pressure. In addition to tobramycin, which is a broad-spectrum antibiotic used to suppress bacterial infection or for prevention when the risk of infection is high. And tobramycin is a broad-spectrum antibiotic with good penetration into the cornea, and it's well tolerated with favorable safety profile. And in addition to loteprednol etabonate and tobramycin, Eyelid also has povidone and glycerin, which are ocular lubricant and ocular moisturizer to improve ocular comfort and ocular moisture. To start with Eyelid, we need actually to start with Lotimax, which is the parent product of Eyelid. Lotimax is loteprednol etabonate, and it's the corticosteroid that we use to describe as tough on the inflammation and soft on the eye. Loteprednol etabonate meets the unmet needs. The unmet needs with the current corticosteroids is that those products, although they are very effective in reducing the ocular inflammation, but they are limited with their adverse events, which include the elevation of the intraocular pressure because corticosteroids inhibit the degradation of the extracellular matrix material in the trabecular meshwork. And this leads to aggregation of an excessive amount of these materials within the outflow channels and a subsequent increase in the outflow resistance. Not only the IOP, but also because of the presence of a ketone group in the C20 position in all the conventional corticosteroids, there is a Schiff-base intermediate that occurs due to the interaction between this C20 ketone group and the nucleophilic groups, such as amino acid group of the lysine residues in the lens proteins. So the interaction between the ketone and the lens proteins leads to the formation of posterior subcapsular cataracts. So IOP elevation and posterior subcapsular cataracts are very common side effects of the conventional corticosteroids. And here comes loteprednol etabonate, which has the smart design. It's the only ester steroid developed for the treatment of ocular inflammation. And we say always that loteprednol etabonate is eye-tailored corticosteroid, because all other corticosteroids have been developed actually for systemic use and then were adapted for ocular treatments. But loteprednol etabonate is the only corticosteroid that is eye-tailored. Loteprednol etabonate is actually a prednisolone acetate derivative just by replacing the C20 ketone group by a C20 ester group. And this was done by what we call retrometabolic drug design. We studied the metabolism of prednisolone acetate in the ocular structure, and we found that prednisolone gets metabolized into active and inactive metabolites. And those active metabolites are the ones that contain the ketone group that inhibits the degradation of the extracellular matrix material, leading to IOP elevation. And those are the structures that interact with the lens proteins, leading to the formation of posterior subcapsular cataracts. So we discarded the active metabolites and we worked on the inactive metabolites in a retrometabolic pathway. So if we reach from prednisolone acetate to inactive metabolites in steps 1, 2, 3, 4, we work backwards on the inactive metabolites in steps 4, 3, 2, 1, until we reach a new compound which shares the same characteristics of the original product, but here it has a lower incidence of adverse drug reactions, because this new compound, which have been developed only from the inactive metabolites, will have a predictable metabolism only into inactive metabolites. And this predictive metabolism happens by single-step inactivation, and this significantly improves the therapeutic index. And that's why when we looked in the previous slide on the chemical structure, we found that we replaced the ketone by the ester, because in the eye there is a natural esterase enzyme. And this is how loteprednol etabonate gets metabolized in a single-step deactivation. And this leads to a more favorable profile in terms of intraocular pressure elevation due to the rapid and predictable metabolism by the local esterase enzyme. And also loteprednol reduces the incidence of cataract formation, because unlike the C20 ketone, the C20 ester does not interact with the lens proteins. But not only the safety profile, but also loteprednol etabonate is 10 times more lipophilic than dexamethasone, because esters are more lipophilic than ketones. So it has higher degree of internalization into the glucocorticoid receptors, and its affinity towards the glucocorticoid receptors are improved. Clinically, loteprednol etabonate is as effective as prednisolone acetate, and in this study, it was compared to prednisolone acetate for patients undergoing cataract surgery, and we look here at the post-operative inflammation. Both loteprednol and prednisolone acetate were equally effective in reducing the cell count and flare scores. However, loteprednol had a more favorable effect on the intraocular pressure compared to prednisolone acetate. And this difference in IOP reached statistical significance in day 3 of treatment. So it's not only with prolonged duration of treatment, even at day 3 of treatment. And loteprednol etabonate has a proven efficacy for ocular inflammation in a variety of conditions, including but not limited to giant papillary conjunctivitis, prophylaxis of seasonal allergic conjunctivitis, biliary-keratoconjunctivitis, and postoperative inflammation. So this is loteprednol etabonate, which is the primary component of Eyelid. Eyelid contains also, in addition to loteprednol etabonate, Eyelid's tobramycin has a broad spectrum antimicrobial effect, and it's effective against many pathogens that commonly cause ocular infections. And we see here like just examples of the pathogens that are susceptible to tobramycin. staphylococci such as Staphylococcus aureus, Staphylococcus epidermidis, coagulase positive and coagulase negative, including penicillin-resistant strains, Pseudomonas aeruginosa, E. coli, Klebsiella pneumonia, Enterobacter aerogenes, Proteus mirabilis, and Morganella morgani. In addition to streptococci, which includes some group A beta hemolytic species, some non-hemolytic species, and some Streptococcus pneumoniae strains. So as we see here, tobramycin has this broad spectrum of antibacterial effect, and more important is its pharmacokinetics, because tobramycin susceptibility levels for common ocular pathogens, we look here at the concentration of tobramycin in the tear film compared to the minimum inhibitory concentration, which is the concentration of tobramycin required to kill 90% of these common ocular pathogens. And as we can see here, that even after 240 minutes, which is 6 hours after a single instillation, a single drop instillation of tobramycin, still the tear film concentration is higher than the MIC90 of most of the common ocular pathogens. How does this reflect into clinical results? This combination of loteprednol and tobramycin in Eyelid. Eyelid has been studied in different studies, and I will just present to you one study just to show how does it compare to dexamethasone tobramycin combinations. We see here in this study, it was done on 300 blepharokeratoconjunctivitis patients. We see here that loteprednol, etabonate, and tobramycin combination is effective in reducing the signs and symptoms of ocular inflammations associated with blepharokeratoconjunctivitis. And we see here that after 15 days of treatment, Eyelid achieved 78% reduction from baseline symptom score after 14 days of treatment. And in this study, it was a comparison between loteprednol, etabonate plus tobramycin, Eyelid, compared to dexamethasone tobramycin, and there was no significant difference between the two treatment groups in terms of controlling the ocular inflammation associated with blepharokeratoconjunctivitis. So in terms of efficacy, Eyelid was comparable to dexamethasone tobramycin treatment, and both achieved the 78% reduction over 14 days of treatment. However, in terms of safety, Eyelid loteprednol and tobramycin combination achieved a better safety profile compared to dexamethasone tobramycin in patients with blepharokeratoconjunctivitis. And as we see here, that there was, we look at the changes from baseline and intraocular pressure between the two treatment groups. And we see here the blue charts are the loteprednol tobramycin Eyelid compared to the red charts, dexamethasone tobramycin. And we can see here that with every visit, day 3, 7, and 15, there was an increase in the change from baseline and intraocular pressure with the dexamethasone tobramycin group compared to no changes in the Eyelid group. And we see also that twice as many eyes in the dexamethasone tobramycin treatment group than in the Eyelid group experienced an IOP increase of 5 to 9 millimeters mercury over baseline. Finally, in this study, which compared the safety profile of Eyelid compared to dexamethasone tobramycin, and here we studied 306 healthy volunteers received either loteprednol, etabonate, tobramycin, Eyelid, 156 patients on Eyelid, or dexamethasone tobramycin, 150 patients at 4-hour intervals 4 times a day in both eyes for 28 days. In this randomized double-masked multi-center parallel group trial, IOP, visual acuity, and ocular health were assessed at all study visits. And as we can see here, that nearly 4 times as many healthy volunteers in the dexamethasone tobramycin group experienced an IOP changes more than 10 millimeters mercury compared to Eyelid treated healthy volunteers over 28 days of treatment. The percentage of healthy volunteers achieving more than 10 millimeters mercury increase in IOP was 1.9% in the Eyelid group compared to 8.7% in the dexamethasone tobramycin group. And now I will just conclude with the prescribing information of Xylit. Xylit is approved by the US FDA, and it's indicated for the treatment of steroid-responsive inflammatory ocular conditions for which a corticosteroid is indicated and where superficial bacterial ocular infection or a risk of bacterial ocular infection exists. Ocular steroids are indicated in inflammatory conditions of the palpebral and bulbar conjunctiva, cornea, and anterior segment of the globe, such as allergic conjunctivitis, acne rosacea, superficial punctate keratitis, herpes zoster keratitis, iritis, cyclitis, and where the inherent risk of steroid use in certain infective conjunctivitis is accepted to obtain a diminution in edema and inflammation. They are also indicated in chronic anterior uveitis and corneal injury from chemical, radiation, or thermal burns or penetration of foreign bodies. For tobramycin, the use of a combination drug with an anti-infective component is indicated where the risk of superficial ocular infections is high and where there is an expectation that potentially dangerous number of bacteria will be present in the eye. The dosage and administration of Xylit, first of all, it's recommended to shake vigorously before using because Xylit is a suspension. And with Xylit, we apply 1 to 2 drops of Xylit into the conjunctival sac of the affected eye every 4 to 6 hours. However, during the initial 24 to 48 hours, the dosing may be increased to 1 to 2 drops every 1 to 2 hours. And frequency should be decreased gradually as warranted by improvement in clinical signs, and care should be taken not to discontinue the therapy prematurely. Finally, the contraindications. Xylit is contraindicated in most viral diseases of the cornea and conjunctiva, including epithelial herpes simplex keratitis, vaccinia, and varicella, and also in mycobacterial infections of the eye and fungal diseases of the ocular structures. And definitely it's contraindicated in patients with hypersensitivity to any of the ingredients. And also it cannot be injected inside the eye. Thank you very much. And if there are any questions, I'm very happy to answer. Thank you.
Thank you, Ashraf. Excellent presentation. Just a question to Dr. Brian, if you have an experience with Xylit. Dr. Brian, are you using Xylit in United States? Dr. Brian, you can just unmute yourself. Dr. Carlos, also, if you have any comment, because here United in UAE, me and Safwan, we just still just now receiving the words. Yes, Carlos, yes.
We don't have it in Spain. We have similar, but we don't have it in Spain.
You don't have, okay. Brian, you can unmute yourself, Brian. You can hear me. You are unmute. Muted. Can you mute yourself, please? I think we have some problem, I think, with Brian.
Hello, can you hear me now? Can you hear me?
Yes, go ahead, yes.
Okay, sorry about that. So yeah, for Xylit, it's an excellent product. We do have it in the US, as well as Lotamax. We use it primarily. I use it. It's a very well tolerated steroid. Doesn't cause as much pressure problems, as much side effects. Like everything in the U.S., cost is a big issue. So, but otherwise, it's an excellent product.
Do you use it after the surgery? I mean, post surgery. How do you use it, or do you use another combination? I mean, this combination, or you are using separate drugs, antibiotic alone, steroid alone, or you are usually use combination?
I usually use more Lotamax than Xylit, honestly, especially for my transplants.
Okay. Any comments, Safwan, if you have any comment about that?
No.
Okay. Mina, I have wonder about one thing. If you want to tell me, to convince me, let me say in this way. So what is the most important things that Xylit it's better than others? The most important, 1 point. Do you think that we should use Xylit instead of others?
I would just say that Xylit provides what we call the soft steroid concept. It provides a similar effectiveness to other corticosteroids, including prednisolone acetate or dexamethasone, with a more safety profile in terms of that Xylit has a more favorable effect on the intraocular pressure compared to the conventional corticosteroids, and also Xylit having the corticosteroid of loteprednol etabonate, it does not have the risk of interaction with the lens proteins. So with in cases of long-term use, which is more relevant to the Lotimax than Xylit for long-term use, it has a reduced risk also of the formation of posterior subcapsular cataract. So it provides similar effectiveness to the conventional corticosteroids, but it is tailored to be used for ocular inflammations in terms of safety, having a more favorable effect on IOP elevation and lower risk of formation of posterior subcapsular cataracts.
Okay, Ashraf, also the last question, it's available where in Gulf area, which country now is launched already?
Gulf region, it is now registered and marketed in the United Arab Emirates, and it is under registration in the rest of the GCC countries. We expect the soonest to have it in Qatar and in Kuwait before the end of this year, and it's under registration in the rest of the region, including the Kingdom of Saudi Arabia.
Thank you, Ashraf. Thanks a lot. Now we can have questions. I have Dr. Sarah, Mohammed, and Nisreen Fayyad. If they are, John, can you prepare them if they want to talk? And Dr. Safan, can you show us the shape of the lens used?
Okay, yeah, you need to see it through the movie, or you need to see it separate, because I don't have it now. I think I can show it through the movie. So let me share. Just give me a chance to share my screen.
Okay, let us while
because I'm not
preparing for the
share my screen.
Let's have. Okay, do you use?
Yes.
This is a question. Use planner instead of paracentesis for MST forceps introduction instead of paracentesis if they are already inserted after pars plana vitrectomy. Dr. Carlos, I think, or Dr. Kim, this one. Dr. Kim.
Go ahead, Dr. Carlos.
Okay.
You're muted, Dr. Carlos.
You or Carlos, whatever, who wants, both of you. I think this one was more to Dr. Carlos, if he can. Do you use the pars plana trocar instead of paracentesis or MST forceps introduction instead of paracentesis?
Yes.
They are already.
Okay. Remember that the cases I shown are the cases that I rescue the same lens, and I use the forceps that I use for vitreoretinal surgery, 23 or 25 gauge. When I have to do Yamane, as Brian mentioned, and the last optical part, then I use the MST with an anterior opening in the corneoscleral opening. I use it for MST forceps to put the second optic in the needle.
Okay, I have this one very fast for Dr. Brian. I know you want to leave, Dr. Brian. Sorry for keeping all our speakers late. What is your opinion regarding four-flanked technique in a very short?
Yeah, I think it's great. The popularization of using 5-O-proline and to create a flange and passing it around, lassoing around the lens and haptics is excellent. I've been a fan of using Goretex to secure lenses for repositioning, but I think using the 5-O-proline to do the same thing without conch dissection is basically like Yamane, but instead of the haptic, you're using suture. And the criticism has always been with polypropylene that they break. but with the 5-O-Proline, you can create the flange just the same. Very efficient. And so I'm looking forward to trying it, but I haven't done it yet.
I have one problem with 5-O-Proline, that, you know, at the end, the lens had to be some tension to maintain it there. And then 5-O-Proline has no tension. You do the flange and stay there. It doesn't contract. Then perhaps you will have subconjunctival or you will break the conjunctiva, okay? Then it's not that easy to put it inside, not that easy. I did it for these, you know, these sutures to retain silicone oil in the vitreous cavity. We put some tension, you know, sutures, and I did it with 5-O with this technique of Canabrava, Sergio Canabrava from Brazil. You know, at the end, it's so rigid that at the end it comes out, stays, you know, over the conjunctiva, out of the conjunctiva. That's
oh, you started to see the suture extrude out, you're saying?
It's not that easy that you put it inside because it's so, 5-O is so rigid. So
yeah. Why can't you just trim it more, make it a little bit?
Yes, but at the end, you trim, and
right.
Okay.
I get you. Yeah. Good point.
Muhammad, just you asked me for a lens, and this is the shape of the lens.
Can just for 1 minute, we have Dr. Basil. He's raising his hand.
Okay.
Who is ready? Can you put him?
Okay, good evening. Can you hear me, Dr. Muhammad?
Dr. Basil, أهلا وسهلا. كيف حالك? How are you?
Fine, alhamdulillah, thank you.
Nice to hear you.
Yes, indeed, I have one comment about Eyelid. Yes, I have one comment about Eyelid eye drops. It will be a good for us after glaucoma surgery, indeed, in cases when we have a blip and we want to keep this blip effective for a long time as much as we can. So Eyelid will be a good option for us to use post-surgeries, as it just affecting the surface of the eye, and this will prevent the fibrosis in the blip itself and will keep the blip active for longer time, especially in cases when we can expect some fibrosis, such as young patients or in inflammatory glaucoma, or yet in some neovascular glaucoma. So this will help us to keep the blip effective for a long time by using Eyelid, which contain antibiotic tobramycin and a mild corticosteroid. This is my comment about this eye drop, one of the indications for using this eye drop. Thank you.
Thank you. Okay, do you have any other? Is Dr. Tara or Dr. Nisreen? Dr. Mr. Not. We have only one question, then we can see the movie of Dr. Do we use 23 for creating of the tunnel? Dr. He already left, I think. Dr.
Ashvan, he left. Dr. Muhammad, just your sound is cutting. It's not smooth. I cannot hear you well.
Okay. Okay, now it's okay. So far.
Yeah, now it's okay. I think that. Yeah, Brian
can you show us your view?
Yeah, I will share, and I need to just to share the screen, and I'll show. This is the lens, and is it clear?
Yes, it's very clear so far.
Yeah, so we have, if you can see the cross, we have 4 eyelets for the physio, and I'm using those 4 eyelets in a way that I'm creating loop here in one side, and then creating another loop in the other side. And this is the issues. Now the centration, because why it's very centered and there's no tilt. And the issues of centration is that we are using from both sides the same distance from the limbus, and there's 4 eyelets. So the chance of the tilt is because we are for example, not measuring the distance from the sclerotomy site to the limbus in a correct way. And this is very rarely happens, if none. Second issues is that the level of the four eyelids makes the tilt or the chance of the tilt very, very unusual. Now, you asked me, Dr. Muhammad, for one video for artisan retro.
Okay, thank you, Dr. Jamal.
Sorry, Muhammad, I'm not hearing you well.
Because we are very late.
Okay, as you.
Yeah, it's very late. We are already reaching more than 3 hours. It will be very late. Brian already slept. Even day.
Anyway, it's a very short. It's a very short movie, Muhammad. Yani if it's only 2 minutes. I don't think so that 2 minutes. You can. I can. Because your sound starts to be very difficult. I'm not hearing you. I will show this technique for the.
Can you hear me very well?
Now I'm hearing.
Safwan, now you can hear me?
Yes, I'm hearing you now.
Okay.
But my echo, the echo is coming through the movie. Anyway, this is an artisan. This is a movie from one of my colleagues. I'm not interested in any product related to the artisan. But the technique here, it's very interesting. See what he start. He start with a needle, because the one that he's doing, I did it before, but I'm not doing it anymore. Now, what he start with a needling, put it in the center, 3 and 9. Now, why he's putting this gauge? This is a needle of a polyproline 10-0. He put it in a 10-9 for the in-capturing of the lens from the back, but both sides, holding the lens inside through around 6.2 or something, because this is an unfoldable. We can use a foldable. Anyway, he put it and rotated, and then he implanted inside. See now this maneuver. See how here he pushed toward the left side, and in this way I went down, because I'm a very curious person. I went down when I did it, and I saw that in the left side I create a trauma to the ciliary body and to the peripheral part of the retina. Now, that's why I stopped using it. Again, we will continue. Now, here in the usual issues, those that they are doing, the artisan, they know that they are holding in the right, and they need to clip. They need to use the left hand to clip the lens to the iris lens clip, and then they will hold the lens again in the left, and they will use their right hand to clip. But in this technique, this is a new technique, he clipped both using the one hand, and then he drew the needle up away. Now this is the issues that you asked me, and I finished here.
Thank you, Safwan. Thank you very much.
Most welcome.
We have Dr. Jamal, if he is there, please. Jamal Ma'mari. So we will finish by Dr. Jamal and Dr. Sarah if they are there, please. Otherwise, we are very late. Dr. Jamal. Dr. Jamal is there.
I think that we are all, only because Brian Kim is in mid and PM, so he's not in late, but we are late. So we are apologize for our audience and the speakers because we are late.
Jamal, he's there, please. John, can you hear me? Jamal, if he's not there. Okay.
He's here, but he unmute again.
Okay, Sarah.
Not here.
Okay, so, we are going to finish with this one because we already exceed the time. I would like to thank dear panelists, speakers for their time, sharing their experience with us, and to have Dr. Brian and again Dr. Carlos. This may be the third time we are together, and we wish to see you again, Dr. Brian Kim, in another webinar soon, inshallah. Thank you, Dr. Safwan, and I'd like to thank you.
Thank you,
Carlos. Thanks, Brian Kim, to accept my invitation, and thanks for all.
I learned.
Thank you, everyone.
Thank you very much.
Thank you.
Thank you.
Most welcome.
Thanks all attendees for their patience and staying till this time with us. We are now around 12 o'clock midnight in UAE. So good night for everybody. Thanks for all. Thanks for Luna for sponsoring this meeting and for Ashraf for his being
Thank you
with
very
us.
much, Mohammed. Thank you.
And good night. Good night.
Good night.